Professor Khaled sir, Dr. Deepak Agrawal sir to please join us. Sir, me? Next
Next, I would like to call upon stage Professor A.K. Mahapatra to talk about this first pediatric neurosurgery course and also the pediatric neurosurgery fellowship that has been started at our institute.
Good morning, Professor Mishra, Professor Banerjee, Professor Balaram, Professor Sharma, Dr. Deepak, all our dignitaries, faculty from abroad and from India. It is indeed great pleasure to talk about pediatric neurosurgery workshop. It has, I think Dr. Banerjee must be very happy because whatever happiness is there today to see that India has grown in leaps and bounds. When in 70, Dr. Ram Ginde wrote about neurosurgery in India. There are 50 neurosurgeons. That is from 1949 to 1970, there are 50 neurosurgeons. Then Dr. Kak wrote in 1989, neurosurgery in the second part of development from 1970 to 1990, that we have 353 neurosurgeons. I wrote the development neurosurgery in 90s and first part of this century from 1919 to 2010, and we had 1600 neurosurgeons. So if you look at the development, formative stage, consolidative stage, and developmental stage, what is that developmental stage? It is unbelievable that neurosurgery has about 8 to 10 super specialty. Neurotrauma, neuroskull base, epilepsy and functional surgery, we have traumatology and pediatric neurosurgery, and gamma knife surgery, and many more. And today we are doing movement disorder surgeries and surgery for all movement disorder. So it is really has gone beyond the imagination what Dr. Banerjee would have thought when he was resident fellow, or even going back 40 years in the history when I was resident at AIMS. So we would not believe that development happened in our own vision, in our own front. Coming to craniosynostosis, when I was first joined in AIMS, I was in pediatric surgery with Dr. Upadhyay, and I saw Dr. Rohtgi and Dr. Banerjee doing craniosynostosis, and Dr. Dhawan and Dr. Tondon doing anterior encephalocele in mid 70s. And coming from Odisha, it was not possible to see the type of surgeries being done here in mid 70s. But things have changed, anesthesia have changed, the technology has changed. There are no CT, there are no ultrasound, there are no MRI, there is no PET scan. So the things have changed in the betterment, which is unimaginable. Coming to this workshop, why workshop? We all know that AIMS was created in 1956 for the three basic components of medical science: world-class medical facilities in patient care, research and education. In general, it aims conduct about more than 300 conference, seminar, workshops in a year. And neurosurgery is committed in the field of medical education and research. Ever since the Neurosciences Center created in mid 70s, we celebrated 50 years last year. We have been doing microneurosurgery workshop, spinal surgery workshop, cadaver workshop, many things like aneurysm surgery and animal experiment cadaver workshop. So we have really contributed to development of neurosciences in India. In that endeavor of developing neurosciences in India, the pediatric surgery was not getting a push to that extent because pediatric surgery has always got a back seat. In 1994, in Bangalore Neurological Association meeting, there was a debate: should India have super specialization or not? And Dr. Tondon was talking against super specialization, and I was talking against in for of super specialization. It is in Bangalore conference. Dr. Banerjee didn't attend because of some problem. But the question is that we have to go forward. Today there is no point of telling I do everything and I know everything, or I nobody can challenge me in any field of medical science. So that is the reason exchange of technology, ideas, skill is very necessary. As you move across the world, then you realize how limited is our knowledge. When you are not moving, when you are not going to other centers, when you are not seeing all others are doing, we are thinking we are top of the world. Then soon you realize, as you meet other people, as you know all others are doing, you know how limited your knowledge, how superficial are you, how less skillful are you. From that point of view, it is very important to develop skill. And today we have, after I came back of 15th of October, I told Deepak what we are going to do extra, what we are not doing. He said pediatric fellowship. Unfortunately, no candidate appeared this time. I was telling Dr. Dev Pujari, our pediatric neurosurgeon, those have come from different India. The pediatric even aims PDF fellowship, nobody applied. So that only show how people are interested in the branch of pediatrics. And that was not surprising when I was in Sanjay Gandhi Postgraduate Institute. We created a 65-bedded advanced pediatric center. And for 3 months, nobody admitted a patient. So I told Dr. Askumar, why not fill up all beds, 65 by pediatric neurosurgery? Because you have always deficient bed, and we have no lack of patient of brain tumor, hydrocephalus, meningomyelin. You gave them 6 month notice. So we filled out 20 to 30 bed by pediatric neurosurgery. Next day, everybody says, you have filled up bed. I say, you did not admit anybody for 3 months. The patients are beds are there, sisters are there, facility. This a 65 bedded advanced pediatric center was not utilized for 3 months. And as soon as I admitted the patient, people are jealousy. So whatever it may be, whether it's jealousy, whether the some ray of hope or the brain wave coming in a positive manner, it worked. So I hope what we are trying to do in 2.5 days, have a model, 3D model handling how to cut the bone, how to advance the skull, how to reconstruct the orbit, how to look after the cosmetic and functional aspect, and also some lecture program and demonstration surgery. And this gives a complete package of workshop, knowledge, and visual and first-hand experience. I hope all of you will benefit by this. Let us hope in the future the craniosynostosis surgery will be better than what it is in India today. Let us hope for the best. Thank you. Jai Hind.
Thank you, sir. I would now like to invite Professor A.K. Banerjee to speak to the audience.
Professor Misra, Professor Balram, Professor Mahapatra, Professor Sharma, Professor Deepak Gupta, friends. I think it's mind-boggling. I was present when Dr. Shifali was presenting the entire spectrum of craniofacial anomalies. I didn't know there were so many. And it really is such an eye-opener. I must say, when I joined neurosurgery, it would be happening, I'm sure. There would be these anomalies all over the country. But I didn't see even one. I didn't see, maybe they were roaming around. They might have come with different problems, but none were diagnosed while we were there. Maybe a couple of craniosynostosis uh, at maximum. Then when we came here also in the beginning years, there was nothing except these patients of cranial meningoencephalocele, they would come. Some or the other, they used to be clustered around UP, and they would come because my predecessor, founder of the department, Dr. Tandon, had some uh, name already in surgery of these cases, and they would have uh, a big encephalocele here, and one of the Hindu gods, Lord Ganesha. The people would come and pray to these children, thinking that they are the newly born Lord Ganeshas. So apart from that, well, slowly and slowly, some of the other pediatric neurosurgery in the earlier years, we were not interested. The beds were limited. We could do only so much. So all craniosynostosis, even meningoceles, hydrocephalus, and whatnot, except for tumors, in the brain, they would all be taken over by the pediatric surgery. They were very happy doing it, and we were very happy giving it away, which was a very silly thing to do in retrospect. But anyway, I think the amount of cases, once people came to know, then they started coming, and then they started coming in hordes, and we had difficulty in giving them appointments and so on, because other people in the city, other neurosurgeons, or pediatric surgeons, they were not much interested. The first real thing, the modified Tessier's operation was done somewhere in the mid 70s, 73, by again Dr. Tandon and Dr. Dhawan, who was a plastic surgeon, and that is quite a landmark as far as real getting into the uh, cranial defects. Facial defects we were then not touching. We were only looking after the cranial defects. Then slowly and slowly, of course, uh, Mahapatra took over, and Dr. Mahapatra was able to get good association with the plastic surgeons, and then the whole story unfolded, which he has already briefly told us that where we are now. And it's a fantastic thing, and this is one branch of neurosurgery. At least I'm talking of neurosurgery alone. Pediatric neurosurgery somehow has been neglected. I feel uh, not neglected, it didn't get the deserved importance. Because by now I would have thought that should have had pediatric surgery units or departments, and nowhere in India I see. There are people with special interest, and there are several of those who have special interest in pediatric surgery, but this has not got the impetus which it should have, knowing that we have a large population and a very large number of young people and a growing population, burgeoning population, which this was a requirement which I hope Dr. Mahapatra and Dr. Sharma would be able to somehow or the other be able to do. I was just telling that such uncommon things once upon a while, and only the few years back I saw a documentary on BBC on a full institute in Australia which does only craniofacial. And it was a very wonderful documentary which really opened the eyes of anybody who had seen that documentary on what all is happening, what is possible. Because these children, they grow up with a stigma and which goes beyond looks, and it's a terrible thing for a child who has it, and to those who look after these children at all levels. Um, I think it's a great tribute to their persistence and their craftsmanship. Well, looking forward to a very good workshop. And incidentally, workshops are meant for two things. Number one, to familiarize everyone with how it is to be done. and still more to tell that it can be done. You can do it. You know, that spirit has to be there. If you see how it is done, the way how to get it done, and that if others can do it, you can do it. And that is the main idea of all the workshops. Thank you very much.
Thank you, sir. I would now like to request Professor Balram Aaron to come and speak a few words.
Namaskar, good morning. Respected Professor Banerjee, our esteemed Director Professor Mishra, Professor Mohapatra, Professor B.S. Sharma, Professor Deepak Gupta, our international colleagues and dear faculty. First and foremost, I am honored to attend this inauguration and congratulate the Department of Neurosurgery and the Neurosciences Center for having organized this first neurosurgical pediatric workshop with special emphasis on craniosynostosis. Now, in AIMS, we are laying more emphasis on organizing the various workshops, not only the Department of Neurosurgery, but in other departments also, because we think that these workshops are much more informative, better attended, and it provides better interaction between the audiences rather than the national annual conferences, which is like a social gathering. Regarding the super specialization of the neurosurgery of this pediatric neurosurgical conference, we are encouraging in the institute in all the departments to start various fellowship courses or the DM courses, because now even the super specialized centers or the courses have become oversaturated. They are also branching in the different directions, and we have to start the new courses. Over the last 2 years, we have started more than 50 such courses, and many more are in the pipeline. Even in the Department of Neurosurgery, just now I was discussing Dr. Mohapatra, we have started 4 new courses, and many more they have suggested, and we shall taking it up in the academic section for the approval. I again congratulate you and wish all the best for this workshop. Thank you.
Thank you, sir. I would now like to request Professor M.C. Mishra to give us your blessings for this workshop.
Professor Banerjee, Professor Balram Aaron, Professor Mohapatra, Professor B.S. Sharma, Professor Deepak Gupta, distinguished national faculty, international faculty, faculty of neurosurgery department, Dr. Shefali, who is the chief of pediatric neurology division, who was just speaking when we entered, all the other faculty members, residents, ladies and gentlemen. As Professor Banerjee was mentioning, when I joined institute, then Professor Dhawan along with neurosurgery were doing these craniosynostosis and complex skull-based procedures and these deformities. And a lot of time has passed by, and so much development has taken place. But I would say that institute, after its inception in 1956, saw significant development in 80s, when the Neurosciences Center, the Cardiothoracic Center, the Cancer Center came about in existence. And of course, in mid 60s, the RP Center came. So the first specialized center to come about was in mid 60s, and then 80s. And now again, what we have been witnessing for over last few years, that there is again a tremendous phase of expansion which has taken place. And it is so much important that we have this sub-specialization or super specialization, whatever we call it. But this is needed for the population of this country. This is huge population. The specialists are very few, and that puts a burden on a few centers and few specialists. And now people look forward for highly specialized people. Some time ago, there was a very elderly gentleman admitted, 98-year-old, with deep vein thrombosis. And somebody to ask me, let him be seen by a venous expert. I said, sir, we don't have a venous expert. We all do it. Every general surgeon is trained to deal with deep vein thrombosis, and we do it. So you can imagine, and this was none other than a union minister that to a doctor. So you can imagine that what expectation people have today, that they are looking for, as we were jokingly used to discuss, in that you have a surgeon doing a right knee replacement, there is a surgeon doing left knee replacement, somebody doing a right cataract, somebody doing a left cataract. So I think we have now come into that phase that at least certain institutions must take up this challenge of capacity building in various subspecialty areas. Professor Mahapatra was right that neurosurgery now has expanded exponentially, and you name so many subspecialties or super specialties have been. So I think, and now the Department of Neurosurgery has a critical mass of faculty members where subspecialization can really work, because the number is such that we can have more than one person devoting to one subspecialty. And I think that is the time we are moving in. And I again welcome the national and international faculty who have come all the way, traveled. And I'm sure the workshop, as Professor Banerjee was mentioning, and everyone agrees that these workshops help in many ways. You learn from the experts who come and operate, you witness them. So those who are already performing these procedures can get finer points from these experts. Then the others who are not yet into the field also think to take up this and develop interest. And that's how I think most of the development in surgery. I was recently reading an article by the American College of Surgeons doing a thyroidectomy through the lower lip. It's just the imagination becoming a reality, that how you can go between the incisors and the lip and take out the thyroid from the neck, or going through the axilla, or going through the nippile-areola complex and taking out the thyroid. So, and it has been, there is a surgeon in Thailand who has very vast experience in doing this. Initially, the minimal invasive thyroidectomy was started in Italy, in Pisa. These group people were going there for exposure training, and then this surgeon in Thailand has done more than 1,000 thyroidectomies through this technique. And this some American who came for training to him, and then he invited him, his center mentioned about this. So I think it is the imagination. If we have to stretch out our imagination. It is the sky is the limit for developing techniques and taking them. Ultimately, what everybody is working towards for the betterment. The whole minimally invasive thyroidectomy came about removing a scar in the neck. Although scar in the neck many a times is not visible, but still people are doing that. And minimal access surgery, the removal of gallbladder through laparoscope paved the way for all other application of minimal invasive surgery in practically every surgical discipline now. So that is how it happens. So I am sure this workshop will be of immense benefit for the residents, for the younger faculty. And also I would encourage that some of you must take up with Dr. Deepak Gupta, so that we are not limited by one person only taking up a specialty, because in institution, continuity is the hallmark of an institution, so that if one person for some reason is not there, then the other person takes up the challenge. So that is something. And now in most departments, we cannot complain. We have good number of faculty members who can actually develop various areas, like the Sumit does the brachial plexus, Deepak has taken pediatric neurosurgery, and Dr. Kale is spine, epilepsy surgery, Dr. Sarachan. So I think Dr. Manmohan Singh, everybody has developed a niche area for themselves, and ultimately it is not for themselves, it is for the betterment of our patients. I think that is the bottom line, that when we do a procedure again and again, we become better at it, our outcomes improve, the patients benefit at the end of the day, and all this development is towards our patients who come with a lot of high expectation, look for the expert, and that is where our strength lies. And that is why, as Professor Balram mentioned, that we have been able to initiate DMMCH program, almost more than 22 programs over last 1.5 years, and 20 almost 32 fellowships, and many more on pipeline in many other areas, and which is very much needed for the society. So I congratulate the Department of Neurosurgery, the Neurosciences Center, which just celebrated its golden jubilee year 1 year ago, and we only have to move forward, and that is what I say, and raise the bar for yourself, and you will not have a problem in developing what you need to do that. Thank you so much.
We are honored to have two distinguished faculty from Brazil, and we would like to invite them on stage. First up, we have Professor Arthur da Cunha. He is from Brazil. He has traveled all the way from Brazil for this conference. He has served as past president of the Latin American Federation of Neurosurgical Societies. May I now request Professor MC Mishra to present a token of appreciation to Professor Arthur da Cunha.
And the moment. Japan.
Hope you enjoy. It's not too cold. How is Brazil? How is Rio right now?
Summer. It's in summertime. 35.
It's not too cold for you?
Yes. Yeah, it's very cold. Yeah.
We also have Professor Takeyoshi Shimoji from Japan, who has been trained under Professor Raimondi from Chicago in 1970s and is actively involved in pediatric neurosurgery. Professor Arthur. May I now request everyone in the gathering to please vote of thanks first. May I invite Professor Deepak Gupta on stage to present his vote of thanks.
Good morning, respected Professor A.K. Banerjee, Professor M.C. Mishra, Director AIMS, Professor A.K. Mahapatra, Chief of Neurosciences Center, Dean Professor Balram Iyer, and my head of the department, Professor B.S. Sharma, the distinguished international national gathering, and the faculty and the residents from the Department of Neurosurgery, and all the attendees of this conference. It's my proud honor and privilege to express vote of thanks. In fact, I give this 2 times in a year because I organize now 2 conferences, and every time before the vote of thanks ceremony, I think I should prepare my talk and so that I don't miss out any names, but I may miss out some names, so I may kindly be forgiven for that. At the outset, I would like to thank Professor M.C. Mishra, sir. He is the director of All India Institute of Medical Sciences, and we in our department, whenever we call sir, he never says no, and he comes out from his really very busy schedule and comes us to bless the occasion. Thank you very much, sir, for coming for this occasion. We have got two pillars for the Department of Neurosurgery, Professor P.N. Tandon sir and Professor A.K. Banerjee. Unfortunately, Dr. P.N. Tandon sir is not well today. He had some mild fever, and so he could not make it. Professor A.K. Banerjee sir, thank you very much for coming all the way to the meeting and for blessing us, sir. And there is a very nice Vietnamese proverb which says that whenever you are eating a fruit, you should always thank the person who nurtured that tree. And so I wish to thank Professor A.K. Mahapatra, Professor B.S. Sharma, and Professor S.S. Kale. I think he should be somewhere around. So, and these three people, they have actually given me the responsibility to organize this meeting at a very short notice. And I hope I'll be able to come up their expectations in the next 2 months. I also wish to thank Professor Balram Aryan, whom I met just last week, to request him to come for the meeting, sir. So thank you very much for coming for the meeting. I also wish to thank all the international faculty, Professor Arthur Kunwa, who is the president of Brazilian Pediatric Neurosurgical Society and was the past president of Latin American Neurosurgical Society. Professor Takeyoshi from Japan for coming all the way. I mean, it's a long journey for you. I believe you just arrived yesterday. Thank you very much, sir, for coming, and we look forward to hear from you.
As long as Brazil.
And not as long as Brazil. Arthur is a regular visitor for our meeting. He comes every year. He loves India, and he is now become a part of India, I would say. Interestingly, in this meeting, we have invited surgeons, both the neurosurgeons, plastic surgeons, and the facial-maxillary surgeons, because we believe and we have understood, as what Dr. A.K. Banerjee said, it's a combined specialty approach to management of craniosynostosis. So we have formed 4 different teams of the operating surgeons who will be doing 7 surgeries in the next today and tomorrow. I wish to thank Professor Dev Pujari, who is the past president of International Society of Pediatric Neurosurgery, Professor Chidambaram, who was the past president of Indian Society of Pediatric Neurosurgery, Professor Nitin Mokal, Dr. Suresh Sankla, who is the current president of Indian Society of Pediatric Neurosurgery, Dr. Shafali Gulati. Thank you very much for coming all the way. And there's so many names I may actually miss out, as John Wayne, the famous Hollywood cowboy. He said, you know, like, giving thanks is a very, very difficult task because you always miss out some important names. 2 names which are very, very important for me today are Deepak Agrawal. Can I see him here? So he does all the work for me at the background. Deepak Agrawal and Shweta Kedia. I'm just the visible face of the meeting who is making a lot of noise, but like a well lubricated machine is always silent, and all the silent parts are working well. Our assistant professor, Dr. Shweta Kedia. Shweta, thank you very much. Dr. Shweta Kedia has done a lot of work for this meeting to happen. And I also wish to thank my administrative staff, Dinesh, Lipika, and Akriti. And I also, of course, the sponsors of the meeting have to be thanked for looking after the logistics, the audiovisual guy, and the caterers. I wish to put and thank everybody. Thank you very much. Now I invite all of you to please join us for a cup of tea outside while the OT cases are getting induced. Thank you very much. So I think John Bennett, if you have 2 minutes, Professor John Bennett from Miami, he's online. So we are live streaming this event to the rest of the world today, and Deepak has actually coordinated with me. And so this event is being live streamed, and John Bennett is online now. Yeah. Hi, John. Good morning.
Audio from the computer.
Is the audio? Audio. John, we can't hear you. So whenever we do something for the first time, there are always some technical glitches. We have already conducted one online pediatric neurosurgical meeting for 2 days. Yeah. Mike. So, sir, we did a 2 days online pediatric neurosurgery course just 2 months back, and this person was awake for 2 full days with us.
It's not good. It's not good. It's not good. It's not good.
We can just wave to him. Probably we'll just get it sorted out. So he's waving to us. I think in the meanwhile, the OT cases have already been induced, and 3 OTs we will be beginning live telecast shortly. And there'll be a lecture by Professor A.K. Mahapatra on the status of the craniosynostosis surgery at AIMS. It's okay. We'll just take care of this probably in time to come. But can he hear us?
Yes, yes, he's hearing.
So I think he is able to hear us, but we are not able to interact with him. So he can hear us very well. So we'll see. I think I invite all of you to join us for a cup of tea, sir, outside right now.
नहीं हो रहा, ज्वाइन नहीं हो रहा, कनेक्ट नहीं हो रहा। ये ऑडियो नहीं आ रहा है इनका, ऑडियो नहीं आ रहा ना उधर से। उधर से नहीं आ रहा। हाँ, उधर से नहीं आ रहा, इधर से तो उनके पास जा रहा ऑडियो। इधर से जा रहा है? हाँ, इधर से तो जा रहा हूँ। कहाँ से बोल रहे हैं ये? यूएसए। यूएसए।
साइड में वाला रहेगा, साइड में उसको
रोजी, रोजी स्ट्रीमिंग अभी बंद कर रखा है। हाँ, हेलो, नहीं स्ट्रीमिंग बंद कर रखा है, मुझे नहीं आ रहा इधर।
फोन निकाल इधर, ये घड़ी के फोन निकाल, कुछ निकल दिया यार, अरे कहाँ से दिया, ये बड़े बड़े देखो फिर, क्या बोलेंगे? हेलो हेलो मंजीत हेलो चल नहीं रहा क्या वो स्ट्रीमिंग हेलो हाँ मंजीत हाँ शिवा हाँ ठीक है डीआई कम कर हाँ तो हेलो कर तो दूसरे का डीआई ठीक है हाँ यस यस हाँ बढ़ाना है ठीक हो सेंट्री तो है
My audio's off. Oh, my audio's off. My audio was off. It was me. Mm. Okay. I assume there's audio. Can we get some audio there? Can we get some audio? Atun, they're prepping a patient that has craniosynostosis, I assume, since that's the topic of the conference. Wow, live brain surgery. I think it's live. I'd like to have some commentary if possible. Arun, there's no sound. Hello.
So our you have come there Dubai, which Dubai, America. That's good. That's good. Yes, that's good. Like that. The only one program. Very right. So from Rio, Rio, South, you took the flight from where? Usually. So that is about 18 hours? 14 hours. 14 and this is 4 hours. Yeah. But from Dubai to here is 3 hours. From here to Tehran is 3 hours, here to Dubai 3 hours, here to Abu Dhabi 3 hours. How did you go to here? We had gone to Frankfurt. Yes. 8 hours, that is 14 hours. Yeah. Because sometimes there are I heard good. And just then to. No, we didn't have anything. We took care in getting Frankfurt, and there we have been studying. Yeah. Like I said, I have to direct to São Paulo. São Paulo to Rio.
Hello. Munji. Hello. Yes. Andy.
Hello?
Hello.
Yeah, what do you want? Hello.
Hello.
Dr. Craniosynostosis. Yeah, Dr. Craniosynostosis. Who's the resident there?
एक मिनट में बात करता हूँ. Hello, T1. Hello. How to बात करवा रहे हैं?
Can you hear me, Arun?
The last flight was his transatlantic. Yeah, no, it is from Tokyo after Korea. Yeah.
Yes, ma'am. Just a minute, ma'am. Just. Hello, T1.
Hello.
Who's the resident there?
This is Gaurav. This is Dr. Pramod.
Hello, sir. So we are ready to go?
Yeah. Because has come to
Okay.
We have just prepared
So we're still waiting the audience to come back to the people and just checking out. You are 5 minutes.
We are not
Connect me to OT2, please.
Yeah, just a minute. संजय OT2 से बात करवा रहे हैं. संजय OT2 से बात करवा रहे
हैं. दोनों जगह मिलकर we are 10 road to 10 road. ये जो है 5 days के लिए है. Next कल भी इसके लिए. Gradual lectures there is very
OT2? Who's the resident? Come, hey.
एक मिनट में बात करवा रहे हैं.
Hello.
Painting work.
Who's the resident? Okay, so we are now. OT3?
Yes, ma'am. Just a minute. That is OT3 से बात करो.
Hello.
Hello. What is the status there? What is the status?
I could not get once.
Okay. Okay. And connector?
Now they are telling here.
Oh, fine. Thank you.
Overlaying it directly are not directors.
Hello, Shiva. Hello. How are you doing? How much is it? Hello. Hello.
Yeah, can you hear me?
Yes, sir.
Okay, so we have positioned the child in seat.
I think they have already intubated OT1. What is the OT1? And OT2 Deepak is there. They are also. Deepak, can you hear me?
So I can hear you.
Tell me what you are doing there.
So we have the child is ready, and we have positioned the child. The head is clean now. The exposure is up to the level of the nose, as you can see. The surgery should be able to see both the objects.
We are not.
The child is placed on the horseshoe frame, and it is a supine position. Head end is mildly elevated.
And show the what is the bone defect in that skull.
And you can see out here.
From here, all their bone defect.
So from here to here is the bone defect. This much area there is no bone. Okay. And you can see the deformity in the child. There is a brachycephaly in this patient. You can also see some angles, veins. If you see what Dr. Mahapatra was talking in the morning, this child is not actually pure structural diastasis. It's actually because of raised pressure. You can see those angles, veins on the scalp out here.
And he has also hypoperfusion in state scan. And he has hypertension.
Okay. सर आपका लेक्चर हो गया?
नहीं हुआ, स्टार्ट ही नहीं हुआ।
तो आप आगे लेक्चर बाद में
My lecture is just like pulling people. So we can start and complete because I have three. I just want to say what is the profile of craniosynostosis in our field.
So I call upon Dr.
Slide. Can you give me the?
Can you have slide? Good morning. I think this is my 42nd years in this institute, and when I finished retired December 2017, I almost 42.5 years, including my residency. I did 7.5 years residency, 4.5 years neurosurgery, 3 years neurosurgery. And 600 beds. Now we are planning to make it 7,000 beds, which are 1,000 cancer patients, and they are forcing us to make 1,000 neurosurgery center in a 30 acres of land, 60 kilometers from here. And they are going to have 1,000 bed cardiac center, 1,000 cancer center, and so when I joined, first posting was pediatric surgery in 675, and I did almost 1 year in pediatric surgery, and they were doing a lot of no, not this one. So there was Dr. Upadhyay. So I joined pediatric surgery, and I was impressed because they are doing many more myelocele, they are doing craniosynostosis, they are doing encephalosis, neurosurgery, no pediatric case except brain tumors. But after that, when I joined neurosurgery, I was in 2 units. one with Dr. Dhawan, who was known plastic surgeon, Dr. Dhawan and Madan, and other was Dr. DML Kapoor and Nagni, who are those GI surgeons. So I was half time general surgery, GI surgery, half time the plastic surgery. And plastic surgery were doing gracilis tendons transfer to head and neck cancer, to dectopectoral plaque, to myocutaneous plaque, and all this in 70s. So my craniosynostosis I assisted when I was a junior resident in general surgery. But somewhere or other, we have not systematically analyzed. I remember when Dr. Banerjee with Dr. Rohgi, the manager of professor neurosurgery, Dr. Rohgi was assistant of pediatric surgery. They analyzed 100 cases of craniosynostosis, and that was in almost 1980s, 80. But that was because the patients were being admitted in pediatric surgery. So we have much not knowledge because we are involved, but it was not predicted that way. So if you look at today, most of the craniosynostosis come to neurosurgery, and some of them also go to pediatric surgery. So if I have operated more than 300 cases of craniosynostosis last 35 years or so, but if you look at how many the pediatric surgery must have done, I'm sure they must have done maybe around another 300 cases or so. So what I'm presenting is purely the experience at AIMS, and this time I'm talking about last 10 years. Because in CME Neurological Society of India 2004 at Indore, I had presented about 15 years experience of 130 cases or so. So if you look at the way they present, this is not unusual that a patient comes late. They delayed milestone, they have seizures, they have diminution of vision because of raised intracranial pressure, and in significant cases will have syndromic cases because they have all problems of. I don't know how many of you know that there are more than 160 syndromes. Till 2004, there are 146 syndromes when I was talking CME of NSI. And thereafter, another 10 or 12 syndrome has been described in craniosynostosis. So we know that craniosynostosis is not a single problem. It's a basket of problems with different syndromes, with different malformation, different associations. And what we are talking today is primary craniosynostosis. If you look at my paper, I published giant encephalocele, occipital encephalocele. Out of 30 cases, 14 had craniosynostosis. So I had to do a craniectomy around the suture, coronal suture, to give extra space for the brain. Last child, I operated a large circular occipital, suboccipital encephalocele in a 3 or 4 months old child. I had to do about 2 inches craniotomy and create a suture because there are no suture. All the sutures are fused. Head circumference was about 30 centimeter and encephalocele was 32 centimeter diameter. So it is always that you have to plan the surgery and tell what all you are doing, because when you do a large encephalocele or craniosynostosis, blood loss, hypothermia, duration of surgery, the patient has to explain the risk. Family has to be taken to the confidence. So when you are talking of today's lecture is primary craniosynostosis admitted to neurosurgery last 10 years or so. So we have single suture, multiple suture, non-syndromic, syndromic, all combinations are possible. But in last 10 years, I have spent more than 7.5 years outside. 3 years in Sanjay Gandhi and 4.5 years at
live stream going to stop.
So I exactly don't know how many I have operated out of these 146. But I also operated craniosynostosis. I think out of 250 operations I did in Sanjay Gandhi in 3 years, the maximum number was the spinal disruption, maybe around 100, maybe 20 or 30.
Can you hear me, Arun? Can
So
you hear me?
if you look at these 140 cases, it is by the different faculty, and many of them may be by Dr. Deepak Gupta also. So you know that patients are demographically, they come late in our place, they are not referred in time. They will be going to many people, maybe pediatrician, general physician, then neurosurgeon before they come to us. So the surgical procedure becomes difficult when the child is older, and we also do not understand much of the brain pathology. That is the reason I asked Dr. Deepak Agrawal in 2005 to do a series of cases of ICB monitoring randomly, those who did not have raised internal pressure. And when we had completed 15 cases, we found all 15 cases had pressure more than 15. They are neither delayed problem, they never have vomiting, they did not have papilledema, yet intracranial pressure monitoring in the operation theatre for half an hour before surgery was showing raised internal pressure. That's the reason why in mid 2005-6 or something like that, we started doing SPECT scan, because no child will be properly evaluated without knowing the cerebral perfusion. Because when you say patient is okay at age of 6 months, it's so difficult to have neuropsychological functional assessment of the child. So if you look at this, there are some syndromic cases, upper, exclusion, hyper, and many syndromic cases. But if you look at that, this is the chunk of the case. And if a single suture, multiple sutures, these are data we have collected. Question is that whether should we do a skull X-ray? It is so obvious that there are problems in the head. So if a child is, there are still controversy all over the world amongst the pediatric neurosurgeon who would not like to have a child less than 3 years given radiation. That contest whether you should a 3D CT for the skull. These are controversies. Nevertheless, people do it for better assessment and better planning. One has to choose between the risk, what you are taking, and how much benefit you are getting. Yesterday, Dr. Chidambar was telling that we are talking about American Association of Pediatric Neurosurgeon, World Association or International Society. By and large, it is consensus is that as much as possible, avoid radiation in a child less than 3 years. If you are definitely do it limited X-ray, proper X-ray, not indiscriminate CT, 3D CT, reconstruction. If you can do less radiation, that will be better. Some patients have other, there are associated hydrocephalus, multiple suture. I think there are also patients with carry malformation, agenesis of corpus callosum, many things are there. So carry malformation, patients have, one patient had torcular encephalus, one had carry 3 malformation. So there are all variety of combination, even though they are not part of the neural tube defect, craniosynostosis, they may have problems with pro-atlas abnormality, atlas abnormality, branchial crouch, branchial cleft abnormalities. So it is difficult to understand all the gametes of spinal dysplasia, not spinal, craniosynostosis, because it will not explain by any one pathology. If you talk about why all syndrome, why cleft palate, why the cleft defect in the face, why corpus callosum agenesis, why adductor, when raised intracranial pressure, why ventricles are dilated. We saw another child, ventricles are dilated. If the patient has raised intracranial pressure, the brain is compressed by the Monroe-Clement doctrine, the CSR will push out the cranial cavity part, but that didn't happen. In presence of raised intracranial pressure, there is increased ventricular volume. So SPECT scan. We started doing SPECT scan almost about 10 years back, maybe more than 10 years back. But it was not a project. Nobody did PhD. No thesis was going to given to MCH. So what happens unless somebody dedicated will do it? We will not understand what is pre-op, what is 3 months post-op, what is 1 year post-op. So everything has to be done dedicatedly. Unless you do have got a proper data for 51 patients, SPECT, how frequently they went, what was the before surgery, 3 months before surgery, 1 week before surgery, 3 months after surgery, 1 year after surgery, then only you can correlate how the brain recovers. So the question is that significant number of them will have hypoperfusion. This is what is accepted. I know Dr. Chidambaram, Dr. Jomna, and all of people know that our friend Professor Kang had done the ICB monitoring in the single suture stenosis in Seoul, and they found 33% of patients had raised intracranial pressure on ICB monitoring. The children neither have clinical manifestation of raised intracranial pressure, nor they have got mental retardation. Yet these children had raised intracranial pressure, which what we don't understand. You say, okay, this child has no mental retardation, no raised pressure clinically, so what is a big deal? It is only functional surgery. No, it's not true. Unless we study them, we will not be able to understand them. So in these 146 patients, 160 operation surgical procedure are done. And if you look at that, mean age somewhere about 3 years, which is not good. Somewhere we have failed to educate our pediatrician, our MBBS doctors, or general surgeons, maybe general neurosurgeons, to send them early to us. So the question is that this is not acceptable. This is okay, but if you see the range, it is almost 12 years, 10 to 12 years, 12 years here. So the range of the age and mean age is much higher than what a craniosynostosis surgeon would like to do. You would like to see the child at maybe at 1 month of age or at birth, follow it 3 months and see how the things have improved, how the baby is behaving, then plan the surgery. I'm not telling that you should operate everybody 3 months. I like to operate them 6 months when the body weight is around 6 to 8 kilo. Blood volume will be about 400 to 500 cc. The child can stand for a 4 to 5 hour surgery, hypothermia, blood loss. So as such, I would not like to operate. All the anterior encephalocele I have operated about 150 or so. We do not, even the child come at birth will say if there is no emergency, there is no hydrocephalus, the surgery should be delayed for an age of 6 months to 8 months, and the child is about 6 to 7 kg. So this is what is that is ideal around 6 months, 8 months. If a child is only 6 kilo, 5 kilo, then you can wait because this is a really concern for all of us. So what all we did? We did around different type of surgery. Most of them, this is the cranial vault reconstruction, cranial vault reconstruction frontoorbital advancement, bicoronocranial advancement, mesh cranioplasty. So if you look at 146, half of them some way or other frontoorbital advancement. So 50% people will require. If you look this slide, this is strip craniotomy, which required frontoorbital advancement. Afterwards, frontoorbital advancement, and then craniotomy, frontoorbital. These are the combination of procedure. After that, you can have another group who had surgery different, but one patient at front. We had one encephalocele repair, one patient with type 1 SCM. So I had one more slide, but the total frontoorbital advancement. If you add all these up, 48 and here 4, 52 and 20, about 72 out of 146 had some other way frontoorbital advancement or frontoorbital advancement with associated or other things. So 50% will require. So what is more concerned about us? We all know that we have become very skillful. But last giant encephalocele I did operation, intubation, long lining, arterial line took 2 hours. We all know that. So operating time may be 1.5 hours or 2 hours. But the anesthesia and when the child was extubated, you are not breathing, the extubation, hypothermia management. So you do an operation for 1.5 hours. The intubation, long line and positioning take 2 hours, and at the end of the surgery it is 2 more hours for proper recovery of the patient. So the question is not on surgery. Good successful result is the good anesthesia, and I believe that there should be very well trained pediatric anesthetists. That is how about 10 years back we were almost writing a paper with Dr. Ramjur, who was a resident here in 2005 to 2007 or 8. Is there a need for neonatal anesthesia in pediatric neurosurgery? Because if you have to intubate a child of 3-4 kilo weight and understand the pathophysiology, physiology and respiratory physiology, hypothermia, then it's very important to understand that. So we have large number of hypothermia. Out of 3 patients who died in last maybe 25 or 30 years, one was hypothermia and one was massive blood loss with a I think this child had sagittal sinus was so badly fixed to the skull. I think there was air embolism, intraoperative air embolism. So transfusion related complications. We all know that sometimes the patient may require massive transfusion, and if possible, this baby can have auto transfusion. This is what I learned from Dr. Carlos Maja from Italy. He was talking about small children harvest blood. Suppose this child lose 1.5 150 cc of blood. You can collect this blood, filter it, and give the autologous transfusion. So we have to also understand if a child has a blood volume of 400 cc or 500 cc, whose weight is around 6 or 8 kilo, you have lost half of the blood volume during the surgery. It is not, you may say a filter cost about 6,000 rupees, a cell saver cost about 30 lakhs of rupees, but what a life cost. What a life cost. So question is that can we go with the impression that these children, whatever blood loss happens during surgery, can be saved through a cell saver, can go through a filter and retransfuse the patient. So if that is the case, then we can prevent the complication of massive transfusion. Dural care, I was doing syndromic craniosynostosis 2009 in a family of two brothers and sister. Brother was 9 years and sister was there, almost become blind of raised intracerebral pressure. When I raised the frontal flap, there was no dura. With the bone flap, entire dura came out. So the question is that yes, it's difficult because so long lasting hypertension, intracranial hypertension, we had no dura. I had to put a total brain, I had to take Casalata or somewhere and put it. So this has happened. I have faced many times. I had a small child, 3 months child, severe syndromic stenosis. Last child I operated was blind in one eye, 4 months child. So dura tear is a problem. That is how non-neurosurgical faculty, when a let us say plastic surgeon operate or a maxillofacial operator, they would be very scared for dura tear. So that is the reason you should always have a neurosurgeon with this team, because even how much skillful you are as a skull-based surgeon or a maxillofacial surgeon, when dura tear, I have seen in pediatric surgery, when they are doing everything, when the dura gets torn in pediatric surgery, they will be thinking that their life is going out of the surgeon's life. So the question is that in the team, if you think the neurosurgeon is superfluous, it's not true. The lot of John is done by neurosurgeon. Even there is a craniofacial team is available, neurosurgeon has to be in the team. So superior surgeon has sinus injury. I remember two of them, but after I was in Bhubaneswar, one more patient had superior sagittal sinus damage, and there was some air embolism. This is the patient I was telling that this patient was operated in 2012, and he was operated at age of 1 year and now at 5 years. So his head circumference, he had no raised pressure. Head circumference has gone from 40 centimeter to 55 centimeter, and the IQ is brilliant. He says that his mother says that he's doing it far better in the school than his elder brother. This girl who came in the morning, this girl was operated in 2012. I think Dr. Deepak operated unilateral plagiocephaly. It was 46 centimeter head diameter, and we had done the SPECT scan. Today she was here for taking the chocolate. The mother has a head circumference. She's a mother and child. This came in last Tuesday to me, not this. They operated last Tuesday, and her performance is far better than our elder sister. So the question is that we do not know what is right or wrong. But when I talk to Dr. Biroko, there are a lot of people in Rome, those who work on the psychological development, mental development, clinical assessment or the performance quotient. So that what we have to also understand, doing the surgery is not only important, following them for their future development, future performance, future schooling is also important. This child was a 4 months old child, 6 months old child. He came to us at age of 5 months, 4 months. In month of September, we were admitted in October, operated. He was already blind. The corneal opacity both eyes, but the right was completely. I think it will require enucleation. It's so badly damaged. So we did the frontoorbital advancement. This child, we have removed the tarsorrhaphy, and child is okay. This is another patient, craniocephaly. I operated in November. 2 years old child. This is what Dr. Banerjee was asking. This metopic suture baby had, I think he has mental subnormal. So we operated this child, and this is cosmetically good. This is operated in November 2016. So there is a lot of scope for improvement. What is the scope of improvement? Skill is not only the improvement. We have diagnostic improvement, surgical technological improvement, post-operative care improvement, neuro-anesthesia improvement, and overall to see that psychosomatically they get proper rehabilitation, proper counseling by the pediatrics. I was telling that yesterday to my psychologist that we should have a super specialty called pediatric neuropsychologist. Pediatric neuropsychologist, and I have given a suggestion that get a course of 1 year fellowship of pediatric neuropsychologist. Unless we have a pediatric neuropsychologist, we will not be able to assess them. So if you have to see what all the scope we have to do in the future, we have to have their diagnostic improvement, skill improvement, anesthesia improvement, post of their follow up, psychosomatic counseling, and psychological assessment. If all these things are happening, the craniosynostosis will be a package of a conglomeration of super specialties, those who can help the overall development of the child, cosmesis, personality, mental development, and also occupational therapy. So I think we should finish here telling that we are here today to discuss the overall how can we improve the care to the children with craniosynostosis. If we can make a team effort, I am telling that we should have specialized clinic for the cerebral palsy children, for the spinal dysraphism children, for the craniosynostosis children, because if we do not have specialized care for these children with a dedicated specialty from the psychology, from the cosmetic surgery, from the neurosurgery, from the neuroanesthetist or pediatric neuroanesthetist, you will not be able to plan them properly. So to get the best result, we have to do our best as a teamwork. If we understand this is not an individual work, because ever since I joined this institute in 1975, I understood when the first craniosynostosis, I was telling Dr. Banerjee, between 1972 and 80, Dr. Chandranathan Dhawan operated 8 cases of anterior palsy, which was published in a child's brain. The child nervous system was named those days child's brain, and there was 8 cases done in 8 years' time between 1972 to 1980, and it was published in 82. When after that only the child brain was renamed as child nervous system. Thank you very much. I just want to share some experience at AIMS, but we have not put from 1970 to 72, 73 till now. It's almost about 43 years or 44 years. I don't have data will be available because we have computerization only from 1990s. So and we don't keep data more than 10 years. There is no space to store data unless you digitize them, and we have no data. Thank you very much. If there are any questions. Dr. Shekhar, you want to ask anything? Or comment anything?
So you have covered the whole spectrum of craniosynostosis, and
yes, Shiva.
What are the complications also, especially in very young age? So I think here there are most of our participants are the ones who are seriously interested in this work and want to carry it forward. So I think the message is very good.
I forgot to tell one thing. On 3rd September 1993, I lost a child because the blood was given by an anesthetist which was 3 weeks old. Please, that is the reason I made it a point when the blood transfusion request is sent to blood bank, right? Fresh blood. The blood should not be more than 2 days old. The child which we lost on 3rd September 1993 was given rapidly about 70 cc of blood, which was 1 month or 4 weeks or 3 weeks old. And when the child had a cardiac arrest, we took the child's blood sample for potassium and the sample from the blood bank. Blood had potassium 8 milliequivalent, and the baby, when he had a ventricular fibrillation arrested in the operation theatre, had a potassium of 6.5 or something. Please see that you are a surgeon, whatever anesthetist give is well and good. No, you have to see that they are giving proper anesthesia, they are giving doses. If they give extra dose of anesthesia, your surgery over, the child doesn't wake up. And this is what I made a point for last 25 years or so,
that every patient I operate less than 6 months, I say fresh blood, not accepted more than 2 days old. If blood is not available, I will cancel the operation. Please make it a point that your operation can wait. But if you go wrong transfusion and the child has a potassium 6.5, nobody is going to excuse you. This I learned after losing one patient. I remember the date because this is in my brain imprinted for my life. The child, 3 months old child, lost his life because the anesthetist gave 70 ml or 80 ml of rapidly blood, which was 1 month or 4 weeks or 3 weeks old. Thank you very much. Yes.
Dr. Mahapatra point is very valid. We cannot ignore anesthesia. You may be the senior most surgeon, person giving the anesthesia may be the junior most. You will have to stop the surgery, ask the anesthetist periodically how the child is. You are not dealing with adults. The margin for error is very, very little in a child. As much as 15 ml, 20 ml blood loss can prove disastrous, particularly if you're operating on neonates. So please make it a habit to stop the surgery at least once in 20-30 minutes and find out how the patient is.
Okay, thank you very much.
Connect us to the OT, OT1.
OT1.
Dr. Pramod, sir, we are with you.
Yeah, Dr. Clock here. Dr. Shweta?
Yes, sir.
Are you able to hear?
Yes, sir, we can hear.
Oh, we have gently started. We are beyond the coronal incision, bicoronal stent incision. After infiltration with the tumescent and the lignocaine sulfate mixture. Are you able to see?
Yes.
Yes, sir, we can see.
Yeah. So we expose both the coronal sutures are closed. Even the sagittal suture is closed. So it's a multi-sutural. And the flap is just going cross. We have already asked for blood around on the table, but then the bone cuts are started, the blood will be started. Give me a bit more, please. Bit more. Squeeze. Dr. Shweta, you can put forward any questions if there are any.
Dr. Suhas?
Yeah, please, go ahead.
Is this a full thickness peritoneal
flap?
flap?
It's a full thickness. The peritoneum is a flap.
Okay.
And the incision is much behind the ear line. We keep the incision behind the ear line and a zigzag one. Wet mouse, please. Wet mouse. Here.
Take us to the other OTs. What is happening in OT2?
Second
OT2.
Mic connected.
Yes, sir, you are connected, sir.
Deepak Gupta sir, we are with you, sir.
Hi, can you hear me? मेरा mic on करो. Hello.
Yes, sir, we can hear you, sir.
So we have just given the bicoronal incision, and it's a zigzag incision I've given. I mean, it's very controversial. Some people like to give classical bicoronal, some people like to give zigzag. But way I have been trained is to give a zigzag incision to avoid any scar and alopecia, giving a cosmetic thing. And we have given local infiltration, and the amount varies. Ideally, it should dilute it as much as possible to make a good dissection plane for adequate hemostasis.
Sir, you are keeping the, hairs intact.
Sorry?
You are keeping all the hairs intact without shaving.
That's the other OT. So, okay.
We have shaved actually. We do the shaving during the surgery. I mean, we do a we hair chlorhexidine hair wash a night before, and we do the clipping on the table.
Okay, connect us to OT3, please.
Hi, good morning.
Morning, sir.
We are just started during the coronary season of the session.
So there's a question from the audience for you.
Yes.
You are operating with all the hairs intact. Is there any chance for incidence of infection in your cases?
With only hair intact?
Yeah.
No, sir. It has been conclusively proved that if the hairs have been washed properly, the shaving causes more chances of infection because it causes microtrauma.
That is at the time of surgery, if you do, that is prevented.
Yes, sir. And I have not noted, nor does the literature support that keeping the hair increases the chances of infection.
Thank you.
Meanwhile, we start with the next lecture. Next talk is by Dr. Devudaris. Yeah. Okay, so we continue.
Keep the theaters on.
So is it okay if the theaters would run on the side screens and we can finish it one talk, or
no? That is better.
Okay, so we continue with the theater right now. So I think you take us to OT1.
Yes, ma'am.
OT1 in the center. OT2 to go on the left hand screen and OT3 on the right hand screen. So OT1 is in the center. Dr. Suhas, please.
Yes. Yeah.
So for the people who have joined us late, we need to know what case is going on, the diagnosis.
Okay, we are operating a multiple craniosynostosis, and physically she had a brachycephaly on appearance, and she's about 2.5 years old. We have taken a bicoronal incision, a zigzag one, a third incision, and now we are just separating the temporalis from the temporal fossa.
Sir, can we discuss the scan also right now, if possible? If one of you can show. You had some.
On the scans. Yeah, we'll get the scans across. Just hold on.
And the special molds that you were talking yesterday, are we using it for this patient? Are we doing anything different for this patient that we were discussing yesterday?
Okay, we're getting the screens across.
Yes, sir. So somebody will have to read the scan for us, sir, what we are supposed to do.
Yeah. Yeah, you're seeing, can you give me okay. Just to point out that. Thank you. Okay, you're seeing the scans here, the 3D recon, and you see the sagittal suture is closed and both the bicorons are closed. The corons are not seen and the sag is closed.
Yes, sir.
So it's a multistructural craniosynostosis, and you can see the brachycephalic effect on the sag views.
Yes.
And you can see the multiple thinning of the bone at multiple levels. You can see the scalloping at multiple levels. So there's an element of raised isopy.
Yes, sir.
There's an element of raised isopy. And what we look for on the scans pre-op is if any ledge of bone is going into the midline sinuses. So I think the axilla I have this wedge, just this wedge, and probably there's an emissary here.
Yes, sir.
Yeah, probably there's an emissary here which we need to be looking into, and otherwise not a very prominent ridge. Needs to be around that. That's okay. Yeah, I think that's a scan.
Okay, sir.
MRI doesn't show any hydrocephalus, and the tonsil is in the low lying side, but nothing greatly worrying at this moment of age.
So what is the plan right now?
We are going to advance the frontal forehead and the bantu, yes, both together, reduce the height and reduce the parietal width. Okay. The width, the height, and the anteroposterior diameter.
Okay.
So that's the plan in principle.
Thank you, sir.
Yeah.
We'll go back to the patient. The audio connected to OT2. Please connect us to OT2. The audio.
Yes, ma'am. Connected, ma'am.
Deepak Gupta, sir.
Yeah, we are just doing the dissection of the flap. We have to go way beyond the nose, the frontonasal suture. So I'm raising the anterior flap first by a combination of blunt and sharp dissection.
So for people who joined us late, we need to revise the case that we're doing and the plan. So the diagnosis and the CT scan needs to be discussed.
So this is a 14-month-old child presenting to us with cosmetic disfigurement of the face, and her genetic workup has been done, which shows evidence of Seidel-Shorten syndrome. So she is a syndromic craniosynostosis, and she has got brachycephaly as a predominant manifestation. Her neuropsych assessment is slightly below normal, and her fundus examination reveals evidence of papilledema. So we have positioned this girl in the supine position with the head end slightly raised up. As you can see out here, there is a big defect in the anterior fontanelle just in the front and running approximately up to 7 centimeters at the back. So I have carefully dissected out the defect. There is no bone in this region out here. Yeah.
Yes, sir.
And we plan to do fronto-orbital advancement, and we will do we make some space on either side by doing some barrel stave or osteotomies in the frontoparietal bone, and probably we'll take some bone from behind and try to give cover to the defect.
Yes, sir.
Is Dr. Mahapatra there?
So he's already left for the OT.
Bye, Panu. Bye, Panu.
Okay, take us to OT3, please.
Yes, ma'am. Connected.
OT3.
Driver, next Darawi, ऐसे कर देते हैं उसको ये देखिए.
Ramesh, sir.
Yes, please.
So for people who joined us late, we need to know the diagnosis again and the
This is a patient of primarily plagiocephaly along with some element of scaphocephaly. We have today decided that we will be concentrating more on the plagiocephaly deformity. So patient has been kept in a supine position, and as you can see, we have started raising the coronal flap. I want to bring it to your notice that the incision has been started posterior to the auricle here, the post-auricular region, as you can see here.
Yes, sir.
And as we are dissecting, you would also appreciate that this is virtually a bloodless field here. There is no bleeding at all, and I think it is primarily because of the reason that we have infiltrated it liberally with adrenaline saline solution containing Hylase. The adrenaline strength was 1 in 500,000, and we waited, and I gave about 100 cc of that solution, maybe more than 100 cc. This ensures that there is a lot of tumescence. The planes have been virtually dissected off by the hydrodissection, and there is hardly any bleeding.
Subodh, can you hear me?
I can hear you.
Yeah, you've got the child in the supine position. How much of sagittal suture stenosis are you planning to correct? We may not be able to go right down to the back.
Yeah, that we have already decided that we will correct only the anterior part of the scaphocephaly deformity. Yes.
Yeah, you may. Going to lambda may be difficult.
Yes, sir. We don't wish to do that today. Okay. Sir, can I have a diagnostic elevator? The heavy one, something heavy, heavier than this.
Okay, take OT1 back in the center screen.
Okay. Just I need blood.
Take OT1 on the center screen.
I want something which is better. I will use this.
Dr. Subhash, sir, we are with you again.
Yeah, so we are separating the orbit. We have separated the supraorbital nerves. The nerves are separated. It was in a small foramen, and the roof is getting separated now. Are you able to appreciate from there? No, I have double it here. Give me a dry mouth, please. Dry mouth. Not quite. 55. 55.
While the dissection is on, I think we can have a second lecture if the audience is interested.
Otherwise, they are not able to interact. Little more clarity.
Subodh, can you hear me?
Right now we are connected to this certificate.
Suhas.
41 connected, sir.
Suhas, can you hear me? Who's online now?
Hello.
Suhas. Yeah.
Hello.
Suhas, are you online? Can you hear me?
Yeah, your voice is very feeble. You need to be loud.
Okay. Now, can you tell us what you're doing and how far inferior you're going?
We are carrying the temporalized muscle downwards on the skin flap. It's on single layer, and we prefer going downwards because we need that bossing to come out and to be flipped apart. Flip in the reverse direction.
Can you show us the frontozygomatic suture so we get an orientation?
Yeah, that's the orbital roof, okay. And my monoflora is on the suture.
Oh, wonderful.
Come on. You have mic to know. Okay. That, yeah. Dr. Chidambaram?
Yeah.
Sir?
Yeah.
Yeah.
So, we can appreciate the supravital rim here, and that is the
Okay. Pramod, you have to be louder, please.
Yeah. The mics are less here.
That's the frontozygomatic suture there.
Yeah.
Yeah, and that's the roof of the orbit. So our bando is going to come from here and go like that.
Okay.
And we are extending our reflection way down so as to address this
the temporal bossing.
Temporal bossing later on.
Okay. Can you, when you're free, can you point out the frontonasal suture so we get a proper orientation?
Yeah, the frontonasal suture is here.
Okay.
We're just separating it, actually not here.
Little more inferior.
Yeah, inferior, yeah. Zoom out, yeah. Zoom out. Zoom out, light please.
Aruna parna. Rohit ipo yan mala tondu
We are covering the light.
ഇപ്പൊ ഒന്നല്ല ഞാൻ പറയടാ പറഞ്ഞിട്ട് അങ്ങോട്ട് വിടാം ഇല്ല
ഇത്രയും നേരം ചലിച്ചുകൊണ്ടിരുന്നത് ഇപ്പൊ
We try to cover to allow the blood, the ooze to stop off. Sometimes most of them stop by themselves.
Are the residents here? Do you have any questions? Residents, juniors, do you have any questions or is everything clear? What are you doing for us?
We are releasing the supraorbital nerve from its foramen. There's a gentle small foramen there, and it's now separate now. It's separate from the roof. We're trying to preserve the nerves.
Suhas.
Yeah.
I think one of you is blocking the OT light. You're not. It's very dark.
Yeah, it's very dark. Better light here.
Can you adjust the light or get more light on the feet?
Yeah.
Yeah, that's better. Thanks.
But though, like maximum. Yeah, better. Better. Very better. Better to side. One more better, please. Keep it there.
What are you packing in the orbit?
A patty so that the venous ooze can be stopped.
Okay.
A patty with sometimes you can soak it in adrenaline.
Okay. Because at this stage I prefer to pack the orbit with the patty soaked in 2% xylitol to prevent oculocardiac reflex. I don't know if you follow that.
Okay. Dry gauze. Please.
That's the frontonasal suture right there.
Okay.
The nasal bone. Your posterior knee of the nandu will have to stay above the frontonasal.
Keep safe. Good morning. Keep my please. Special. Move the lady, please. Thank you. Move it, take it inside, sir. Move on the side. Move on the side. This hand, you get other hand can be. Dry more. Keep it dry.
On the side, this is
Hello.
Okay, put OT2 in the center screen, please.
Ma'am, for a minute, can we go to OT3?
Okay, take us to OT3
Yeah.
in the center.
Yes, ma'am. OT3 connected. Yeah, Dr. Raju was telling me that the neurosurgeons generally would raise the flap in a plane which is with the pericranium along with, whereas I have raised the flap in the subpilial plane, about an inch above the supraorbital margin, I have gone subperiosteal.
Yes.
And I have taken care that we save these vessels, which you can see. This is the supraorbital vessel on this side. This is supraorbital vessel here. You see that cross piece. And so the purpose is to save the supraorbital vessels so that this whole of this pericranial flap, which is this coronal flap, can be raised as a vascularized flap and can be very easily taken into the skull base region. I don't wish to carry this periosteum as part of the flap because I want that all the bones should subsequently be covered with the periosteum.
Yes.
But here then you have the freedom to play with wherever you want to cover. There you are committed.
Okay, Subodh.
Please.
Subodh, can you hear me? I can hear you. Yeah, can you show us the landmarks? How far inferior you've gone?
Just give me a byproduct. Just give me a minute, sir. एक राइट एंगल दीजिए सोचिए जस्ट योर राइट एंगल so sir this is, as you can see, this is about we have inside the periosteum about a centimeter and a half above the supraorbital margin, and then you can see here that I have exposed the nasofrontal suture here. This is the nasofrontal junction, and we have also dissected the part of the roof of the orbit here, and laterally we have gone till the fronto-zygomatic suture junction here on both sides.
Okay, where will your bandu be in relation to the pericranium you've cut?
Sir, the bandu will be in this location. It will be superior to this.
Above the pericranial cut.
Yeah, above the pericranial cut, sir. Okay. Okay, yes, sir. Periosteum and setting थोड़ा थोड़ा उस पर guys से थोड़ा सलाइन इरिगेट कीजिएगा थोड़ा 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 ध्यान दीजिए this acts as a lubricant. Moment please. Thank you. Thank you so much.
Hello, auditorium.
Yeah.
We are going to OT2.
Hello.
Yes, take us to OT2.
Shweta, can you see?
Yes, sir.
If you look at the supraorbital complex out here, the supraorbital nerve, and look how big is the bone work we have to do. Can you see?
Yes, sir.
The other side we have separated successfully, but see these kind of anomalies you see, and Dr. Chidambaram was talking about yesterday. In very young children, if you do, you really don't need to worry about it, but we'll try to preserve it. Can you see?
Yeah, very clearly.
And you look at the bone, the amount of bone which is making up, we have to be drilled out, right?
Yeah.
And the other side we could separate it very, very nicely. That's the other side if you see carefully. Can you see?
Yes, sir.
So this side we have preserved carefully, and we'll see. We'll just try to take care of the bone, and we'll try to preserve it. Okay. Mr. B1. Dr. Mahapatra को दे दो माइक. So I'm now deroofing the
Deepak,
So,
can you not use a fine osteotome and cut it off?
yeah, we can do that, but this is how I do it usually. टीजर है क्या इसका? टीजर कर देते हैं। Gone.
Never mind. Nothing will happen.
Finished you? One more time. वो अंदर से वहीं से आ रहा है, वहीं से अंदर से है वो। बटन दबा के नहीं तो चीज़ कर रहा है। इधर लगाओ। ये को देना। मना करो। वापस शिफ्ट करो। चलो। वो करें? नहीं, अड़कना नहीं है। अभी कर दो, मना करो। मना करो। कंफर्ट से देना। इसका ऑपरेशन है ना, प्रियस्टिक इसको याद नहीं आ रही है मन को देना सही से जल्दी को पैटिंग ला के रखना और थोड़ा सा मुझे टुकड़ों में लेकर रखना ये सारे एक्सटेंशन हमको पैटिंग चलो पैटिंग बेस्ट बहुत अच्छे हो नहीं आप आ जाओ आप आ जाओ
Please take us to OT1, please, on the center. OT1 in the center.
OT1 in the center, please. Suhas, can you hear me? Suhas, hello. Subodh, Pramod.
Dr. Subhash, sir, we are with you.
Subhash.
OT1 audio, please.
Hello. Yeah, Subhash. Hello.
Can you hear me?
Yes, sir.
Yeah. Can you explain the markings for the flap?
Hello.
Pramod.
We can hear you.
Yeah, tell us how you're marking the flap, please.
ये तो बाइपोलर कर देते हैं इसको हेलो
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 who can hear me?
hear you कैसे पढ़ी दो हेलो
Subhash or Subhash, who can hear me? Subodh.
कटी देना We can
put OT1 in the audio, please. OT1 in the center and audio OT1.
Hello.
Hello, who's that?
Too dark actually.
Yeah, adjusting.
एक निकला देना
OT1 audio.
ऊपर देना
Now people who have to see them, they can't see it screens.
Sister,
OT1 audio, please.
एक प्रोसेस खुलवा लो, आप एक प्रोसेस ले लो. Sister,
OT1 audio, please. Or the one on the right. Subodh is also marking out the flap.
एक और पैटी देना, पैटी. इतना फटाक से.
Yeah, can you hear me? Hello?
Yeah, yes, Pramod, go ahead.
Hello?
Yeah, we can hear you loud and clear. Go ahead.
Hello?
Hello?
We can hear you. Hello?
So can we can you hear us?
Yeah.
Go ahead, tell us what you're doing.
Can you hear me?
Loud and clear, tell us what you're doing.
Okay, fine. Give me we've started with marking or reflection speed. Okay, so that's the. I hope the light is right. Is the light okay? So yeah. This is the frontonasal suture here. This is the frontozygomatic suture, and we have reflected the temporal bone as well down below, and the posterior extent of the reflection is behind the maximum curvature of the skull. Okay, so we have to start the reduction. If we want reduction, we have to go behind this, behind the maximum height. Otherwise, whatever you do to the anterior region will not make much of a difference in with regard to the height. So what I was mentioning in the morning, we do a variation of the geometric correction. See, if you look at this, the biparietal width is too much. So this has to be reduced. Right? Even the forehead height is also more. So even this has to be reduced. So the bandu marking is pretty much same. Can you hear me?
Yeah.
Yeah. The way bandu is marked is the same. It is 1 centimeter from the supraorbital rim margin. Yeah. So the bandu is extended sideways like so.
How far into the temporal region do you go?
Yeah, that is not finalized now. That is not finalized now. I keep it open here. And the lower cut of the bandu starts at the frontozygomatic suture. Right? From there again it curves and comes forward, keeping approximately one centimeter.
So the picture quality is not good. The cameraman can.
Is that better?
No.
Can you see?
Lighting is no.
Can we get that light also? This is sterile or unsterile? Get that light also. Forward. Is that better?
No, sir. The image is dark.
Can you adjust the focus of that?
Only
get it this way.
Only Subodh's theater is excellent.
Is that better?
Better.
Better, right? Yeah. So that's the frontoorbital bandu mark. That's the superior line, 1 centimeter from the supraorbital rim, and this is the frontozygomatic suture here. So the bandu lower cut curves up from the frontozygomatic suture and goes behind. Now I have not determined or decided on the extent of this. It is kept open, and this will be finalized only once we decide on the frontal flap. Now, if you can see here, I have marked the frontal prominence. Again, these are arbitrary, right?
I decide based on the curvature that is required. Okay. So that's the frontal prominence, and but you try to make it symmetrical with both sides. Yeah. Now the next step is to measure the distance to the midline. Now here the distance to the midline is 6 centimeters on one side, and it is 6 centimeters on the other side. Okay. Yes. So but we have to reduce this distance. What we routinely keep is 3 centimeters from the midline. You have to get these frontal prominences 3 centimeters from the midline. So you measure that. And draw a line here. And measure this 3 centimeter. And draw a line here. Right? So these two lateral flaps are going to come to the center. These two lateral flaps are going to come to the center. And we have to reduce the height again. So the height to frontal prominence is 4. Which is more? We keep that at 2.5 centimeters. So I have to reduce the height by 1.5. Right? Which will be there. Which will be here. Right? So this mid segment will come out. The lateral flaps will go in. The lower segment will come out, and this will go down as well. So you get nice frontal flaps. Now, if you need, you have to determine how much of lateral extension is required for this, so that you get a nice, a good, smooth curved forehead lateral curve. So you can go back for that. Come there. So
Sir, you can please show the measurements once again, please.
Yeah, I'll do that. Can I get a irrigation? Pencil. Yeah. That's the midline. This is the frontal prominence. This is the frontal prominence. Yeah. And that's the frontoorbital band superior cut. Superior cut. Now we want to have this frontal prominence 3 centimeters away from the midline, right? So you measure what the distance is 6, right? So you want to reduce that distance. So you measure 3 here from the midline, and that's there. Similarly, on the right side, it's again. So you want to reduce 3. So you take that. So these are the new frontal flaps that are going to come in, for the forehead, and these two are going to come out. This will go laterally. These two segments will go laterally, right? Even the height is more. Right? You want to keep the frontal prominence 2.5 centimeters from the supraorbital margin. So currently it is 4. You want to reduce 1.5 centimeters, right? So you're going to take away 1.5 centimeters from the frontal flap. And these two flaps now will come here. Now there's one more thing that is going to happen. Now if you have seen the what I had mentioned during the presentation, the forehead is forward slope. Forehead has a forward slope. It should be a gentle backward slope. So how that can be corrected is by rotating the bamboo downwards like that. You rotate the bamboo so that that will change the, you rotate the bamboo like this so that that will change the slope of the forehead. And your posterior extent will have to go behind this. So once you take the frontal flap out, you will take the parietal flaps also out. But that way we come to it when once we take these bone flaps out. So your bandu extent is now, you know, this is the frontal flap, and that is where we will stop the frontoorbital bandu, the posterior extent, right there.
So camera alignment is what?
Yeah, Pramod.
Yeah, yes sir.
Camera, you have to adjust a bit.
Camera alignment is exactly.
I'm sorry.
I know the light, there's something. Your gain is too much.
Shweta.
Your gain is
Can
too
we
much.
get that on the center?
Which autism? Which one? Right hand side?
Yeah.
Reduce the gain.
Dr. Ramesh Sharma in the center, please. OT3 in the center, please. It's there in the center.
Yeah.
Professor Ramesh sir, we are with you. Sir.
We can hear you.
Yeah, what is happening? Can you show us?
Yeah, can you hear us?
Yeah,
yes,
yeah.
Yeah, so right now we have marked our craniotomy flap. As you can see, this is the marking. We have made 2 burr holes. Half of the cut has already been given, and he is going to start making another cut. Here.
Can you show us the anatomy and the
marking
landmarks?
Okay, can I get the pencil, please? So this is the anterior part, this is the posterior part, and we have dissected it right up to the root of the nose, and this is the marking of our craniotomy flap. We have created 2 burr holes. One burr hole is here, other is at this level, and Dr. Raju has already given about 40% of the cut. Now we are going to start from this burr hole and then complete rest of the cut. So here we start.
So what will be the plan exactly?
Right now the plan is to do the craniotomy, then we will discuss rest of the plan.
Okay.
हम करने पाएंगे पानी शुरू कर देंगे Excellent. मैं करता हूँ उसको ये वाला पढ़ना ये बड़ी वाली मुझे तो यार कंजूसी करता है सिलाइन डालने में सिलाइन तो सस्ता है यार डिमोनेटाइज भी नहीं है ये मैं तो सिलाइन इतना इस्तेमाल करता हूँ पीपल टेल मी दैट आई हैव वन बाबा सिलाइन बाबा हर चीज के लिए सिलाइन कोई बात नहीं खोल देगी तो कोई बात नहीं हाँ वो होती है चलो कोई बात नहीं
ये है जुड़ा है बोल में ना फ्रस्ट्रेशन है कटेगी जुड़ा है ये रिच भी है हम इसके उसमें ठीक है देखा तेरे से रिच ये देखिए आप जस्ट लुक एट दैट दिस इज रिच वो जो रिच है वो तंग कर लिया दैट इज रिच सो जाएगी हाँ हाँ तो इसको ऐसे काट देते ऊपर से ना हाँ जी हाँ हाँ ऐसे कर लेंगे हाँ तो उसमें जो भी स्टक होगी आपको सेट आउट करना पड़ेगा उसको दिस इज वेरी कॉमन वो सिस्टर एक स्विच पैटर्न होता है जो थ्री प्राउंड होता है वो ऐसे रखकर उसको खोल सकते हैं और स्विच पैटर्न मैं देखा आपके सामान में पड़ा है सो ऐसे ऐसे सेपरेट हो जाएगा कोई बात आपने वहाँ सामान में रखा हुआ है मैंने देखा है स्विच पैटर्न ना डेप्थ में रख मैक्सिमम इंस्ट्रूमेंट को यही थे सामान स्विच पैटर्न द सिस्टम इज लाइक दिस इट हैज थ्री प्रॉन्ग्स जब उसको खोलते हैं तो ये दो ऊपर चले जाते हैं एक नीचे चला जाता है ओपन सब इसको देखना एक बार यहाँ पर देखा था मैंने कहीं सुबह जब आप दिखा रहे थे ना आई नहीं ठीक है पेशेंट अच्छा हाँ जी हाँ जी हाँ जी हाँ जी और दीजिए मैं करूँगा एक्सीलेंट ये देखिए ऐसा है भी तो कोई बात नहीं ये इधर है थोड़े बड़े बाइक कर लो दीजिए हाँ जी तो इसको रख लीजिए रख लीजिए Very simple. Pressure बड़ा हुआ था. ये Yes. Jump over hand. Oh, अच्छा. Oh, yes. हाँ जी, हाँ जी, हाँ जी. Yes. Hello. तो ये लगा इसको थोड़ा सा कट आउट कर देते हैं. इसको मैनेटॉल देना है इनको. मैनेटॉल के लिए मैनेटॉल लिखते हैं. राइट. ये कुछ हाइपर डिलीट कर ले.
Suppose, is the brain very tight?
Yes, brain is very tight.
Yeah.
Brain is very tight. Yeah. इसको इस्तेमाल करेंगे. इसको यूज करने. Hang on. हो गया. ठीक है. ऐसे मत. हाँ जी. और ये हाँ. Right. Very nice reception. Consensus. Hello. इधर भी चले गए थोड़ा. 42 connected. This is picked up to the.
Deepak, what's happening?
So we have made the bifrontal ciliated flap. The dura was slightly adherent, and we have been able to separate it. We have marked out the frontoorbital band. If you can see out here, can the camera person show it here?
Dr. Mahapatra likes to take a wider one. He has taken approximately 2 centimeter above the conduit, and this is the lateral extent. He has gone up to 6 centimeters lateral. Can you show us here? And this is the lateral limit out here on this side. So brain looks quite foolish. That's a sphenoid being. Can you see? So this is a child with a brachycephaly. What Professor Chidambaram was telling in the morning. You can see this hypertrophied sphenoid. So spatula change. Spatula. So that's a sphenoid ridge. Can you see, all of you?
Yes, sir.
Yeah, that's a sphenoid ridge. B1, B1, B. या B5 जो भी आपके पास अंदर चलेगा B1 without foot plate. या इधर करना वो करना ये करना यहाँ करना Can you see? एक ऑर्बिट के लिए मुझे स्पैचुला वन मोर स्पैचुला यहाँ पोर्टल नहीं एक पोर्टल है ऐसा पोर्टल ऐसा एक पोर्टल आपको आएगा बहुत दूर है ये ऊपर पोर्टल है ना इसके नहीं इसमें टच तो करें आपका टच आपको टच निकाल निकाल चलो ऑडियंस श्वेता
हाँ जी सर, ये दे दीजिए सर। डॉक्टर महापात्रा सर की आवाज नहीं आ रही, इट्स नॉट ऑडिबल।
Okay, Dr. Mahapatra is cutting through the sphenoid ridge from inside.
Sir needs to have a mic also with him.
Can you hear me? Can you hear me?
Yes, sir.
So I'll speak on his behalf.
Okay, sir.
So he's making the cuts both from inside and outside, and he's using B1 without foot plate. You can use the reciprocating straw if you want to, but this is how we are doing it out here. So through the sphenoid being is already cut. He has cut to the orbitozygomatic suture already on one side. यहाँ से CSF वहाँ CSF बटन दबाओ उसको कुछ नहीं है ब्लीडिंग नहीं CSF
There's a corbett separate नहीं होगा. There's a corbett separate नहीं होगी. So there's a corbett separate नहीं होगा. चलो. फोटो मिली. मेरे पास फोटो नहीं चाहिए.
Connect us to OT1, please. Connect us to OT1.
Hello.
Hello.
Yeah.
Yes, sir. We
I can hear you. Hello.
OT1 in the center, please.
Hello.
Yes, sir. We are there with you, sir. So, can you tell us where are you right now?
Hello. Hello.
Hello. Which audio is connected to us right now?
OT1, ma'am.
OT1. Dr. Suhas, sir?
Hello.
Yes, sir. We can hear you, sir.
Yeah. The craniotomy is going on along the lines that we have marked.
Yes, sir.
Yeah. And if you can see, we take a lot of care to preserve all the bone dust and see to it that it is not just washed away. Because, yeah, we can utilize it. Yeah, good. You're going to come across, right? Give me bow, please. It's okay. It's okay. Oh, you're going to come across like that, right? Yeah. Can you take a picture from there in your phone and send it to me later? Irrigation, please. Yeah. Yeah. Pendulum is similar. Give me a pencil. Chatigo. Yeah. Just turn down and then come just below this. Yeah. Sharpness. Marker. You wouldn't start. You start from the center so that you can, get irrigation. Yeah. Better sound out. Yes, there. If the industries, yeah, I'll push it. Pencil on the bit. Yeah. ഇങ്ങനെ ഇത് കണക്ട് ചെയ്യാൻ പറ്റില്ലേ നേരെ come like this. Give the pencil.
Put OT2 in the center, please.
Shweta?
Yes, sir.
What we have done?
Sir.
We have separated the dura around the defect. Can you see that? This is the. Can you give me a pointer? Give a scale. Shweta?
Yes, sir.
Can you see there is a midline bone defect about 5 centimeter?
Yes, sir.
Can you see that?
Yes, sir.
And it is going from the anterior frontal till here.
Yes.
So what we have done, you have identified the bone margin all around. Look for me. This is the anterior part of the bone defect.
Yes, sir.
This is the posterior part of the bone defect. Yes. You see here, and here the right side. This is the left side.
Yes.
And the bone edge is felt here in my finger. So this is a anterior posterior bone defect about scale. Anterior posterior bone defect around 10 centimeter. If you look at here, this is 10.
Yes, sir.
And if you look here, this is 4, and this is around 6. So the bone defect in the midline going from anterior to posterior 10 centimeter and laterally side to side about 4 to 6 centimeter. We have to bridge this gap in the midline, okay?
Yes, sir.
And this bone edge is ejecting out.
Yes,
so I have to cut off this portion of bone.
Right, sir.
So what I'll do, give me the cutter.
So the posterior limit of the frontal craniotomy was coronal suture here.
Yeah, we have just in front of the coronal suture.
Just in front.
Because we want to go the parietal bone taken to reconstruct the midline.
Yes.
Put back. This abnormal bone in the midline I am cutting off. यहाँ से ले लें. Now we have made it symmetrical.
Yes, sir.
Now here I'll make it symmetrical because that bone is bulging in the midline. Not midline, like cotton hai ka? Okay, now midline defect we have made it wider and we'll put it now across. Now we'll just give me. इसको कर दें? हाँ? है ना? One more. पानी पानी से. Okay. Can you see?
Yes, sir.
What we are doing? I am giving.
We're making radial osteotomy, sir, to just flare it up.
This was designed by John Jane in 1980s. John Jane was the editor of Journal Neurosurgery from Virginia. If you want, we can take few bone here. Now you give the bone which was, okay, laga denge. That is not ready now. Na? You show them what the orbital cord you have given. Can you show us? Light. See, we have seen the dissector. You see the orbit?
Yes, sir.
This is the frontonasal suture.
Yes, sir.
This is the right frontozygomatic suture.
Yes, sir.
This is the left frontozygomatic suture.
Yes.
We have taken a band of both sides around 5 centimeter to slide it off so that it can fix medially and laterally both.
Okay.
And this bone we have refashioned. So whatever extra bone was bulging out, we have taken it out. Yes. Now we'll put it like that. So that will cover the midline, leaving a gap laterally. Okay. Now the frontal bone will be gone. We'll just fix it, the bando, with a 1 centimeter, 1.5 centimeter advance. And here, what has happened? It was so adherent, one other tear in the surgical sinus. Can you see that which was bleeding?
Yes, sir.
This is here. I have put 2 sutures.
Okay.
Here, anterior most of the surgical sinus.
Okay.
Can you give me one more stitch? One more stitch.
Can you see the cutout piece of the bone?
We'll show you just now. Stitch dura forceps. There is a little hole on the anteriormost part of the surgical sinus. I'm just putting 2 sutures. Okay. I've just put one, maybe. और एक लगाना है यहाँ. वहाँ से bleeding तो नहीं. What is the temperature? Can you give me the sir? Okay. इसमें क्या लगा? प्लेट एंड स्क्रू में लगा क्या? ये तो ऐसे था ना, प्लेट एंड स्क्रू लगाना. वो फिक्स नहीं होगा, ये फिक्स नहीं होता. ठीक. इसको काट दो. जहां पर हम लोग ने ड्रिल करा था ना, सुप्रा ऑर्बिटल नर्व, वहां से बोन टूट गया. कैन यू बिलीव? सी दैट इन माय हैंड?
Yes, sir.
The supraorbital foramen was like a foramen. There was about 5 millimeter where Dr. Chinnabaram was asking why are not using the cutter, and we are punching it out, and the bone was thin there. When I tried to put it out, it broke. So they have put the PDS, but this is loose. This is loose.
We want to
You can you see it's loose?
Yes, sir.
So I used to put these sutures in 80s like this, but here I would like to have rigid fixation.
Yes, sir.
So in 1980s we used to wire, okay, 22 gauge stainless steel wire. Now because he has put Weichel, this is Weichel, 10 Weichel, but I am not. See now, can you see this?
Yes, sir.
This is. So what I will do, I will slide it forward by 1.5 centimeter, like this. It was here. It was like this. Can you see that?
Yes, sir.
And that is by pushing it forward, we create a gap, which is called expansion of anterocranial fossa. This is the gap.
Yes, sir.
So what we'll do after per measurement, we'll make an advancement of 1.5 centimeter. If you look at here, yes, if you look at here, this is the posterior cut of the bando.
Yes.
Can you see that?
Yes, sir.
And if you look at here, this is 2 centimeter. I always do overcorrection. So the advancement will be between 1.5 to 2 centimeter, so that we don't want to worry if you in future redo or not redo. Because you underdo it and enable that cut of maybe. If you under advance it, let us say we do by 1 centimeter,
yes,
and the future there is restenosis, there will be a problem. So I would like to do 1.5 to 2 centimeter advancement.
Right.
Now we have only left with the fixation, nothing else.
Right.
See, we have done parietal work, we have done frontal, and we are now putting whatever the bando was broken because of we nibbled some bone around the supraorbital foramen. Deepak, what is the time? 12:30? Oh God. वो तो मीटिंग खत्म हो गया.
Take us to OT2, please.
We are in OT2.
Take us to OT1, please.
Yes, ma'am. OT1 connected.
OT1 is on my head. Yeah.
Dr. Subhash, sir, we are with you.
Yeah, hello? Hello?
Hello, yes, sir.
Yeah, we are just getting the cradle across. We are on the midline. No. We are on the midline.
Okay, sir.
Can you give us a moment to concentrate?
Yes, sir. Yes, sir.
Yeah, just a moment.
Take us to OT3, please.
Yes, ma'am. Thank you, ma'am.
We are removing the orbital bandule.
Yes, sir.
Almost done. The problem is we didn't have a good.
We didn't have the oscillating saw and no osteotome. Good osteotome.
Took us some time to arrange all these things.
Yes.
Okay.
Done almost.
अभी भी चलता है यहाँ पर रहता है थोड़ा सा मैंने ये वीडियो वॉल बना इधर का बस
Hello. Yes, Dr. Rajiv, is there?
प्रिपेयर कर लें
I think you just finish off with OT2 in some minutes, and then we can.
This OT2? 3?
Yeah, if he can wait for 5-10 minutes, OT2 is going to finish. Yes.
ठीक है फाइनली वही है ओके जो मैं देखता हूँ बिकॉज इसकी जो बोन को ना मैं करता हूँ हाँ जी ठीक इसमें जो बोन पीसीस थे वो कहाँ हैं This is Selaima. एक मुझे बोलेंगे आप मेलिएबल दे दीजिएगा ये किसके कर रहा है अच्छा लगा दीजिए
Put OT2 in the center, please. Sir, Mahapatra sir, we are with you.
Okay. What I have, sister, give that bone I have taken out. Sister, give that long bone. Bone जो लिया था अभी लंबे लंबे.
Camera adjust करो OT2.
और एक बोन था. ये सब टेढ़े मेढ़े बोन है. What I will do? Either I will take bone from here and put it in the midline, or we will fix it in like that.
So the camera needs now.
See, there is a big bone gap.
Zoom in, please.
There is a big bone gap here.
Yes.
So either we have to take parietal bone, fix it. What I have done, the bone hump which was there, I have cut it.
Yes, sir.
The two bone hump here. If I put those cut piece, it will still big gap.
Yes.
So I can either take one of this piece, both sides, reconstruct the midline.
Yes.
And Deepak is fixing that window, then we will fix the plate and screw.
Yes, sir.
दीपक हुआ तुम्हारा नहीं हुआ? आई थिंक यहाँ से एक पीस ले लें. सिस्टर कट कर देना. अच्छा तुम लोग ऐसा करो, उस पर ये बोन रखो. ये पीस एक ले लें, यहाँ लगा दें. ये पीस एक ऐसे लगाना या जैसे लगाना? ऐसे लगाना चाहिए ना. हो गया स्क्रू फिक्सेशन. तो यहाँ करो ना, वो लोग देख लेंगे. क्या उधर क्या हुआ? कनेक्टिव नहीं हुआ? बड़ा होल नहीं बनाना यार. बड़ा होल बनाएंगे तो स्क्रू ये है ligament. Can you see that? This is the area of the ligament. एक टावल क्लिप दे दो. या हो गया. ये बोन रखो, कभी फिर जाएगा तो मुश्किल होगा. नहीं तुम्हारा ये बोन इधर था ना. तुम्हें कहाँ लगा? कैसे लगा? कैसे लगा? इधर लगना था. ऐसे तो नहीं था. ऐसे जानने तो नहीं है. एक मिनट इसको फिक्स करो उस एरिया में. देखो सिमिलर एडवांसमेंट होना चाहिए ना. देखो ठीक नहीं हुआ. ऐसे होना चाहिए ना. आ गया स्टेप है. और थोड़ा सा मोड़ दो.
Connect us to OT3.
ना ना OT2 को लगा देखा है।
OT2.
अच्छा दिखाओ। हाँ? क्या नहीं बना? इसको निबल करो। इसको निबल करे। निबल करो। निबल कर दो। क्या नहीं बना? ये हाँ वो तो कहाँ मिल जाएगा? इसको फिक्स करेंगे जो ना पता लगेगा ना राइट पोजीशन में। हाँ हाँ इसको थोड़ा निबल करो थोड़ा ना ठीक है ना ये नहीं ठीक है देखो इसको यहाँ से थोड़ा काट यहाँ पूरा नहीं काट पूरा नहीं फिक्स नहीं होगा ना नहीं थोड़ा हाँ ओके नाउ यू सी 1.5 सेंटीमीटर एडवांस करेंगे ना यू फिक्स दिस साइड फर्स्ट हाँ दीपक ये बोन में यहाँ से लेकर लगा रहा हूँ मिड लाइन में यहाँ से लेना पड़ेगा नहीं तो होगा नहीं।
Connect us to OT3 please.
Yes,
OT3. Professor Sharma sir, we are with you.
Okay, so we have removed the bifrontal craniotomy piece. As you can see in this piece, on the affected side, there is gross recession, which can be appreciated if we just place a molded thing over this. We find that this bone is gone back by about centimeter plus. And when we have a look at the corresponding frontoorbital segment, this also shows that this part is gone down. There is gross recession in this region.
Yes.
So we need to build this up. So we have many options for the bifrontal craniotomy piece. I was thinking, since this part is flat, if I were to divide it into two parts, by dividing it in the midline, and then if I move it counterclockwise, so that this part comes in the front and this part goes in the back. So the forehead will be reconstructed using a bone which is flat and corresponds to that. So I'll just see if that is possible or not. Then we'll come back to you.
Okay.
Thank you.
So what was the posterior limit of your craniotomy?
The posterior limit of the craniotomy would be somewhere, I think he can show you there.
Okay, sir.
This is around 3 centimeters behind the corner suture.
Okay, so did we do like the maximum height, etc. of the skull and then we decide? Because this patient also has scapho, we don't plan to handle that right now.
We might partially handle it here,
Okay, sir. Thank you.
Thank you.
Take us to OT1, please, right
So
now.
we scale below.
OT1.
OT1 connected.
Hello.
Yes, sir.
Hello.
Yes, sir.
Yeah, we have taken the frontal cranial bone flaps out.
Yes, sir.
The midline had some ooze because of raised ICP probably and some emissaries.
Yes.
We're taking the bandio out, and to some extent we'll use the craniotomy itself with the guard.
Yes.
The brain was tight. Now it's relaxing good. There are some small dural tears as expected and anticipated. We'll tackle it probably beyond our craniotomy.
Okay. Connect us to OT2, please. OT2 in the center stream.
Yes,
Yeah, no.
Mahapatra sir, we are with you, sir.
Okay. See what we have done. This is the bando.
Yes, sir.
We have to now fix it. Now make a fold. We are advancing by 1.5 to 2 centimeters or so. Make a fold here, Deepak. Spatula there. So put a durag.
Now you now to give the scale so that we have advanced. Deepak, quick. No, जाएगा ना. नहीं हो रहा है तो फिर एक मिनट ऑब्लिक रहा और सब कर लो. हाँ तो ऑब्लिक रहा. Shweta, can you see?
Yes, sir.
We are fixing that lateral. नहीं जाएगा. नहीं जाएगा. What to do now? एनएच बोल रहा है. ये लगा सुनो मुझे दे दो C1 दे दो मुझे. हाँ इसको प्रोटेक्ट करो. प्रोटेक्ट ऑन ये ना. क्या हो गया? ओके वी हैव टू पुट वन. यहाँ देखो कितना एडवांस करना है. कितना लंबे लंबे डाल रहा है ये तो ऑब्जर्वेबल नहीं है ना. तो इसमें यहाँ भी यहाँ बोल रहे हैं ऊपर से कर दो. फिर काटना कोई काट है चार जगह से काट दो. यहाँ से चार फिक्स करने के बाद काटना मुश्किल है. इसलिए मैं बोलता हूँ पहले काटो जितना. ये तेज बन जाता है ना. सीधा करें ना लगाने के बाद काटने से इसको ऐसे काट दूंगा. इसलिए मैं बोलता हूँ हम लोग रियल स्कॉल पे करते हैं. ये दूसरा जगह में मिलेगा. ये प्लेट स्क्रू आपको सिस्टम स्क्रू यहाँ लग जाएगा. हाँ एक प्लेट रखो फिर. केवल दे दो. कितना 10 मिनट होगा. केवल देखो नीचे से प्रेशर नहीं जा रही नहीं. पछला दे दो. पछला हाँ उसको कहाँ गया. पछला दे दो. नहीं तो ये स्क्रू भी निकल जाएगा. ये बूंद में रख दो गिर जाएगा बीच ना. देखो बूंद यहाँ से निकलने जाए इतना डाले ये देखिए यहाँ पर ओके हो गया दिखा दो इसको फिक्स हो गया अच्छा वो फिक्स हो गया इसको फुल बनाओ ये फिक्स ऊपर करता है इसको हटाओ इसको पहले इसका अंदर कैंसर लिगामेंट ये वाला ना ये वाला रीड बता रहा हूँ ना इसका एम ठीक है ना लेंगे है ना उसको आप फिक्स करने की जरूरत नहीं है बट ये रीड का बात करो ना बट इसको एम दे दो ना C1 दे दो इसको C1 कर C1 B1 जो भी देना चाहिए हाँ सर
Take us to OT3, please. Put OT3 in the audio. Sir, Ramesh sir, we are with you.
Yes. So what we have decided is that we are going to rotate the bifrontal craniotomy piece by 180 degree. You know, this is the original position in which this part is recessed.
Yes.
But the posterior part is flat, is reasonably curved on both sides.
Yes.
So what we were thinking that we could just reverse it this way. So this forms the new forehead, which is flatter and symmetrical on both sides. And then the frontal bendo will also fit into that. The frontal bendo needs to be, this frontoorbital segment needs to be built up in this region because this part is recessed.
Yes.
So we are going to harvest a bone from the midline here in the posterior part. That bone we will use as an only bone graft here to augment the deficient bone on the frontoorbital segment.
Okay.
So Dr. Raju will now take out piece of bone from the midline here. ये मैं इस तरफ हूँ ठीक right. काफी बड़ा पीस है ठीक है
You have to pass plates and many plates and conference hall. We are going to OT2.
Okay, take us to OT2.
Cheta,
Yes, sir.
we have already fixed up the vendor
Yes, sir.
and we have fixed the inner canthal ligament. See, I have made hole here by C1. You see that orbit?
The camera needs to be focused.
Okay, you see that? You said यहाँ पर break हो गया था supraorbital nerve था.
हाँ जी सर.
These we have fixed laterally. These we have fixed laterally, advancing 1.5 centimeter.
Yes.
Then we have taken the orbital ligament here.
Yes.
Okay, and fixed up the here in the hole. We have another orbital ligament here. 4 places because we have separated the periorbita from the bone. So I see here the suture, can you see?
Yes, sir.
Fixed to bone.
Yes.
Here the periorbita fixed to bone. Here one place and here 4 places we have to. Now what will do the midline bone, big
Yes.
bone, big bone. Now you see this big bone we have taken from the midline.
Yes, sir.
This will come like that.
Yes, sir.
Maybe like that. No. Reverse. Okay. See, this is how the bone was here. Okay. What we are going to do? Go like this. Okay. Go like this. Bone is advanced about 3 centimeter.
Yes.
So there will be a gap. So when I was putting bone like this, can you see that?
Yes, sir.
This much advancement is done. This is the gap we have created in the skull plate.
Yes.
So when you push this bone forward, there will be a gap here. So now put a plate and screw here. Here, put here, put here. कोई ध्यान दे दो ये फूल बनाने की जरूरत नहीं
Yes, 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 yes. Yes. ये बोन निकाल के 10-10 सेंटीमीटर लॉन्ग अरे इससे बड़ा वाला है क्या 5 mm? नीचे लगाने को तो थोड़ा सा हाँ कितना इतना ज्यादा नहीं तो क्यों पूरा करना नहीं जा रही No good. ये दो जा जो भी है भैया इतना टाइम नहीं उसको अरे 2 घंटा का ऑपरेशन 4 घंटा नहीं लगाना चल भाई यार क्या मुझे समझ नहीं आ रही अरे सेल कटिंग लगा दो ना ये ऑपरेशन क्या है सेल लगाओ इसको टाइट करो ओके ओके all right now give the big bone because what I want this one of the bone will take it here okay yeah go देखो सुनो दीपक इसको और थोड़ा बड़ा कर दूं इसको काट दूं बट अरे यहाँ पाचला लगाना यहाँ पाचला नीचे और नीचे लो और नीचे नहीं उससे नहीं लगा इसे नहीं ऐसे लगा दो ना मिड लाइन कवर कर जाएगा वो बोन ठीक नहीं है ये देखो ऐसे इसको फिक्स करो
आएगा नहीं, ठीक नहीं है, इसको टेढ़ा मेढ़ा ना, सिमेट्रिकल बोन नहीं है, इसको ब्रेक करो ना फिर। नहीं नहीं क्यों हट रहा है, इसको ब्रेक हो गया ना, इसको इसके साथ ठीक। अरे इसको काटो, यहाँ लगाओ ना, एक 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 पीस यहाँ लगाते हो, अब गैप यहाँ नहीं प्लेटन इसको लगा दो, ये और एक पीस देखो यहाँ फिक्स हो जाएगा क्या, ये ऐसे क्या आएगा, यहाँ से क्या निकाल रहे यहाँ जाएगा, तुम्हारे यहाँ क्या पाएगा, क्या फर्क है तुमको, हाँ चलो इसको फिक्स कर दो पहले, देखो मिड लाइन आ जाएगा ना कंट्रोल नहीं आएगा, ये कंट्रोल चाहिए बेटर, कुछ बेटर, ये बेटर है हाँ, पहले इसको फिक्स कर दो। हाँ इसको फिक्स, इसके बाद तुम फिक्स कर दो, दिस कैन कैमरा कैन गो टू 3 ना 4 GB, आगे आगे देखो ठीक आ रहे ना, चलो 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 जस्ट 2 मिनट ना, दो तो नहीं बजा ना, सोचा को बोलो थोड़ा दिखा दे, हो गया क्या
सर, वी आर विथ यू, वी आर वाचिंग यू।
हम लोग को देख रहे हो?
हाँ जी सर।
हम वहाँ क्या कर रहे हैं, इसको यहाँ मिडलाइन रिकंस्ट्रक्ट कर रहे हैं। ओके, व्हाट वी हैव डन, जो गैप मिडलाइन में था, वी हैव ट्रांसफर्ड टू लैटरली, फिक्सिंग द बोन इन मिडलाइन।
यस
सर, that is enough, one is enough. We'll just now we have fixed everything. There was already bone defect, so we cannot help it. So instead of midline defect in the over the sagittal sinus,
सर भिजवा दिया ऑलरेडी।
Okay, now I am going to fix here. ये दोनों फिक्स करके एक यहाँ लगा दो, नायलॉन लगा, ऑथराइज जोन ये पेरिक्रम से लगा दो, ये पेरिक्रम में स्ट्रिप लगा दो, you make hole C1, this will be fixed to pericardial, ये पेरिक्रनल एज है ना, नायलॉन में करना, ये दोनों मिडलाइन फिक्स कर दो, ये जो पेरिक्रनियम है ना, ये सारे फिक्स हो जाएगा, पहले इसको नॉर्मल में कर दो। Cheta,
yes sir,
we are fixing the bone in the midline, then ना आराम से बात, ये कब मुझे दे दो।
So here we are not doing the rigid fixation, so here we can fix it with the sutures.
मैं कुछ कर सकता था, निकालना, ये लो, now put in this hole, ऊपर से रिफ्लेक्ट डाल दो, कहाँ से ऊपर से फिर नॉट कैसे जाएगा, अरे क्या बात कर, होल नहीं हुआ, इसका ऑब्लिक्विटी तो किस डायरेक्शन में हुआ देखना पड़ता है ना, क्या होगा, पहले इसका थ्रेड खींच लो पूरा, Aspect of the return come. इसको भी फूल लगाना पड़ेगा ये भी दो तीन फिक्स कर देते हैं ना नहीं तो दे दो मैं तो इसके यहाँ पर लगा दूँ यहाँ एक मिनट होल्ड इसको नहीं जाता है अंदर से यहाँ पर 61 hold इसको स्पैचुला इसको फिक्स करो लगा सकते हो 3 होल वाला ये गिर जाएगा यहाँ खोल दो एक स्पैचुला दे दो हमारा पहले डिस्ट्रैक्टिव जो आया था ना वो बोन फिक्सेशन में बोलते थे you remember that oh yeah Shweta
Yes, sir.
now you have to, can you see the midline bone?
Yes, sir.
We have created gap here
Yes.
gap here but cover the sagittal sinus from here to here
Right.
this is around about the bone edge is here.
Yes.
So what we have covered, there is a bone defect of about anterior posterior 12 centimeter.
Yes.
But we have taken about 2 centimeter, 10 centimeter long, and 4 centimeter. Can you do the scale? Which has just covered scale. Scale. Anyway, we just want to cover anterior posterior sagittal sinus,
Yes.
leaving the gap. So now it has to see that. See the bone we have covered,
Right.
around 9 to 10 centimeters. Okay?
Right.
And we have left a gap this side, about 2 centimeters. The 4 centimeter gap in midline is transferred laterally, 2 centimeters this side and 2 centimeters.
On that, yes, sir.
Then 44. We are now going to close.
Yes, sir. Thank you. Any questions from what is the total blood loss, sir? Estimated blood loss?
230 ml.
Okay.
इसको यहाँ से काट दो
Any questions from the audience for Dr. Mahapatra?
Okay, यहाँ से काट दो.
Okay, so now the camera will shift to. Take us to OT3, please.
If you put the.
Take us to OT3.
ये ना एक्चुअली इसको करेंगे OT3 कनेक्ट करना है इसको ये कैसे था अभी ऐसे नहीं इसको अंदर कैसे लगाना हमने ऐसे ये हाँ ऐसे जाएगा पहले इसको इधर कर लेते हैं फिक्स हम एक्सक्लूसिव यार इसको थोड़ा सा वो कर देते हैं ये थोड़ी ना फ्लैटन आउट कर दें इसको
So, Professor Ramesh.
Yeah, just give us a minute. We'll just come back to you.
Take us to OT1. Take us to OT1, please.
Hello.
Hello. So we are.
Yeah. The frontal plaque is out and the band is out.
Yes.
We are getting the parietal passing out because that is the highest point of the height of the cortex.
Okay.
So we're getting the both the parietal bone out.
So both the parietal, so we going to the rhabdoid suture, sir, here?
No, beyond the parietal passing.
Okay.
Beyond the parietal passing. So that we control the height of the construct.
Right.
Silver, sir. Create, Gaurav. Create, please. That's all there. We have one sort of age, you know, that in terms of neurological age. Okay, serious one. Yeah. Those bones are thicker, is that? Is that Gaurav? Do you notice? These bones are thicker than the frontal bones. What's my data? We need to control the height, isn't it? So it's okay. We are beyond the height. This portion will be take a mosquito hold the bone. Take a mosquito. No, take a mosquito. Use something to hold. Alex or mosquito to hold the bone. Something. Ready? Come here. Gently, hold on. Ready? Okay. So mark it still. This is left one. You can watch right hand, sir. Watch right hand. Yeah. Otherwise, the height will not come down. No? Wash, sir. Wash. Wash. Thank you. Okay. Give me number 4, sir. Keep them back mark. Right hand bend, sir. One more. patty. I don't think I like it. Yeah.
Take us to OT3, please.
OT3 around जाएगा नहीं आगे चलो उसको स्मूथनिंग नहीं हो पाएगी चलो दो कोई और स्क्रू को मोटा स्क्रू दे दो चाहे बेशक स्क्रू में भी इवन थिकर नहीं ऐसा है आई नीड ए लॉन्गर स्क्रू इट मे बी इवन ए बिगर डायमीटर कोई प्रॉब्लम नहीं है स्क्रू लंबा दे दो आप हमारे को नहीं बेटे ऐसे है ना आई वांट एज ए पोजिशनल स्क्रू एक स्क्रू ऐसे चला जाए वो फिक्स हो जाएगा उसके लिए लेग ज्यादा चाहिए हमारे को डजंट मैटर इवन इफ इट इज थिक क्योंकि एक बार फिक्स हो जाए ना दो जगह देन वी विल जस्ट कंटूर इट एंड देन पुट इट बैक वहां से आपकी ये चलो कहीं भी डाल लो जहां भी आप करेंगे अच्छा ओह you're thinking much ahead of me वो नहीं दिक्कत है इधर बड़ा इनोवेशन है कमाल करती बस शुभ ओके थोड़ा सा और करो थोड़ा सा और करो थोड़ा सा और करो बस ठीक है दीजिए अब स्क्रू दीजिए बढ़िया है कमाल कर दिया आपने तो बट लेटरल थिंकिंग हेलो
OT4 connect हुआ क्या?
यस मैम
Okay, take us, get OT4 in the center, please.
यस मैम कनेक्टेड
Dekho, Jarissa, we are with you.
Hello, good afternoon.
Yes, sir.
We have exposed the deformity.
Sir, can you take us through the case once
Yes,
again?
yes. So this patient had a metopic cynostosis.
Yes,
there is
sir.
a frontal prominence here.
Yes.
Then this is the open front end here.
Yes.
Okay. We have identified the orbit. If you see the orbit, the shape of the orbit is sloping like this.
Right.
We have to remove the orbit and break it open.
Right.
And we have to create a new forehead because this forehead has got a deformed shape.
Yes.
What we have decided is that this is the template of our new forehead. With a malleable retractor, we have made a new template. So this will be a new frontal forehead. And this will be brought, if you see that you require to reconstruct with the new forehead here. So this particular segment, we are going to remove it and place it in the midline here.
Okay.
On this particular template, I am going to mold this orbit. You can see the orbits which are sloping down like this.
Yes.
Which I am going to break it open and fix it to the new forehead.
Okay.
And this particular frontal cranial segment, we are going to break it into two to replace this two part of the segment which we are going to use.
Right.
We are not going to disturb the coronal part. You see this part we are going to not undisturb. So the central part of the coronal sutures and everything is intact. What we are going to take is the posterior segment which will be reconstructing the forehead.
Right.
So already done multiple bore holes, dissected the dura, they have taken the cuts. Now we will be removing this craniotomy segment.
So routinely, sir, the template is usually from the both the parietal.
Depending upon which is the best area.
Okay. Sir, you're not audible.
Yeah, for the pagiocephaly, we compare with the opposite side.
Okay.
That particular segment we compare. So how much is the anterior posterior, how much is the vertical. That template we use it into the normal the shape which is proposed.
Okay. Take us back to OT3, please.
One. So we created a small countersink hole here. Okay. First. Okay. बाद में देख लेंगे घटना क्या सुधरा था थोड़ा सा और कर दूंगा आई थिंक से टू दिस आल्सो और कर दो इसको और इस साइड में और कर दो जैसे पानी नहीं आता
Take us to OT1, please. OT1.
Hello.
Yes, sir, we are with you.
Yeah, so we have got the parietal bossing out.
Yes.
And complete cavirectomy has been done.
Okay.
We are at least beyond 2/3 now. Are you able to see? I don't know.
Yes, sir, we are
focus,
seeing
focus,
that.
focus. Yeah, except the temporal bossing.
Yes.
Rest all is completely out till the posterior third.
Right.
Only the lambdoid and beyond is remaining.
Right.
Some dural tears here and there which we are trying to repair now. And Pramod is working on the bench already, working on the bones.
So, can we see, sir, how he's working on them?
Yeah, yeah. Pramod, bring the camera there, okay? Yeah, we'll flip it out here. We'll get the.
Right, you can see him.
Yeah, we want to change the mic to. Okay, can you hold on? We'll change the mic to Pramod.
Yes.
Yeah, the mic to Pramod, please. Change the mic.
No, just hold on.
The lunch is also open for everybody, so delegates may go and have their lunch. Take us to OT3, please. OT3.
Hello.
Yes.
Okay. Yes. This is our reconstructed frontoorbital segment. As you can see, I'll show you from the inside.
Yes.
We calculated. Have a look at this paper. We calculated that the length of the orbit in mediolateral direction on the normal side was 3.5 centimeters, and on the affected side it was 3 centimeters.
Yes.
So the plan was to increase the width of this orbit by half a centimeter. So that what we have done, we made a cut here and then expanded it by half a centimeter and put a bone graft here. Right, and which has been secured in place by a mini plate. And then there was the frontoorbital segment here. The bone was deficient here, so this needed to be augmented. So we have taken a bone graft, which we have just placed over this as an onlay bone graft, which has been secured by positional screws, which have been drilled to the native bone here.
Right.
So this now pretty much, and this is the midline. So this is the midline here. This is the midline here. So you can see, so they are almost symmetrical from here to here, and from here to here. The orbit length is almost same. Like if you can see, not from midline, but see from the medial edge. So this is now 3.5 here, and this is already 3.5 here. So this will now, the patient's eye, which looked little smaller on the affected side, will look normal. And then, as we have discussed already, we are going to reverse our frontoorbital segment by 180 degree. We are going to rotate it, so the posterior part will become anterior part now, and our frontoorbital segment will be fixed to this, so that we have a forehead which is almost symmetrical, not really, but almost symmetrical as compared to what it was earlier. So our next step will be that we are going to fix this to this part, and then we go back to the head. Now we have thigh table, then we go to the main table. Thank you. इसको fix कैसे करना है इसको? There are many ways we can either fix it with plate लगा देते हैं, plate लगा. We'll go there. We'll check it. We'll check it. This I have already corrected. Yes. No, that we will adjust when we are putting the plates there in the frontorbitals and the zygomatic frontal junction. There we can adjust. Okay. So what I am thinking is, we'll fix it. This is the midline here. This midline is almost near. So this will be like that. Okay. Just fix it like that. एक प्लेट लगा देते हैं, बड़ी रोड लगा दें, हाथ में यहाँ पे लगा देते हैं प्लेट. इसको छोटा कर लेते हैं. 2 holes will be enough, 1 on either side, but 2 on either side करते हैं. 3 holes करते हैं. We have to call out some exercises. नहीं काट रहा है.
Okay, take us to OT1, please. OT1.
आपको उधर से मिल रहा है? Okay. If I remove this, is it any better? Its head is coming. No, right? Is that okay? Yeah? You can see? Yeah? Hello?
Yes, sir.
Yeah, can you hear me?
Yes, sir.
Yeah. So this is the bango.
Yes.
So I have adjusted the midline of the bango a little bit. See, this is very thin bone. Yeah. So
fracture here. So what I've done is, it was very flat. Okay, I have made it a little convex. Right now we have to reshape the bamboo. So if you see here, see this is the lateral orbital rim. This is the frontozygomatic suture here. It is usually at this level that the forehead slopes.
Right.
Okay, but here we can see that the forehead is sloping at this level.
Right.
Right. That's because of the increased width. So we have to bring the curvature back to this point. Right.
Right.
So that's what we are going to do. Did you get the round curve? Round curve here. I had asked for round in this your craniotome. You can put a round, no? Round bit, not in that. Yeah, cut. Yeah, round cutting board.
Take us to OT4, please.
Hello.
Yes, sir.
Now we are on the lateral wall of the orbit. We remove the orbital band.
Yes, sir.
We are on the lateral wall of the orbit. Malleable. दूसरा एक malleable दे दो. Get the letter. And now start taking the cut in the roof of the orbit. Okay. है ना? अलग अपना तो ऑर्बिट inert area. ¿Vale? Ya, really? Okay. Okay. Very good. Yeah.
OT, connect us to OT1, please. OT1.
OT1, cameraman. Yeah. Yeah. Can you hear me?
Yes, sir.
Yeah. So see, what I am doing here is that I am reshaping the bando, right? So this is a good time to see, as I have done only one side.
Yes, sir.
Is it visible?
Yes, sir, it's visible.
Yeah. So I have done the left side. So this is the supraorbital or roof of the orbit. So I have taken off a part of it from the inner side, inner aspect.
Right.
Yeah. And then I have, now it is green stick. Can you see how
Yes.
it bends?
Yes, sir.
Yeah. So this part, when it bends, that also goes in, which we don't want. So I have made another groove here at this point and brought that out. So this way, you can reshape the bamboo. Now, if you look at the reshaped side and the untouched side, you can make out the difference.
Right.
Yeah. Something like that. Yeah. So this is reshaped now, the bamboo. Now what I do is I take the bone flaps at this point in time. Take the left side bone flaps. Yeah. So this is the left side bone flap.
Yes, sir.
Okay, I mark it to know which is the medial, lateral, bottom and top. At this point in time, we can put this flap on and see how it is on the curvature, which is Not bad. Just hold on for a second. See, it sits along the curvature of the newly reconstructed band.
Yes, sir.
Like that. It's a good fit. Like that, you see?
Yes, sir.
So it follows the curvature of the new bamboo.
Right.
Okay. So we will fix again with the, we are going to fix this with resorbable fixation. If you want to see how the resorbable fixation is used, you can see that now. Earlier I used to put it on the outer side. It's easier putting on the outer side. If the bone is, here the issue is the bone is very irregular, so it might be difficult. But so that's why I'm going to put it on the outer side. At least in the midline, I have put it on the inner side.
Right.
I'm not sure if you can see it. I have that's all over the place. So I use a double plate like this, and try to stagger the screws on either side, which will give little more structural stability than the using a single hole plate. Okay.
Right.
So we have. Can you show this? This is a water bath. Okay. This is warm water.
Right.
So when you dip the plate into the bath, it becomes this type of plastic. You can mold it into the shape that you want to. Yeah. So what you do is you dip it into the water bath and then put it onto the bone and wait for a second, and that's going to set. Right. So now this plate is going to hold the bamboo in the position that you want. Okay? Yeah, like that.
Sir, one piece.
So there are different ways to drill. This comes with a battery operated power drill like this. But I don't know if this battery has been sitting for too long and it's drained some irrigation. I'm going to cut the excess of the plate out. This can be cut with scissors, just regular scissors. You can cut between the holes. So that's the bone, like that. Irrigation, please. So you can use the power drill if there is enough power in it. Right. Painful. Not drilling. And now the pins. Take the pins. There's one pin left, right? Be careful. Yeah, take it. So the pins come in cartridges like these. There are five pins in each cartridge. Yeah. So the pins can be taken on. This is the sonic driver. So what it does is it creates ultrasonic vibrations on this tip, which will melt this pin, which is made of polylactic acid, and it will go into the screw hole. So you, no, I need that. I need the footstep. Come closer. So you place the place the pin into the screw hole. Make sure that it is engaged. And once it is done, you press the foot pedal, and it will gently melt into the hole like that. And once it has gone in the amount that you desire, wait for 5 seconds and then you can take it out. Right? Right. It's going a little bit more, so you can again press. It will go in. There you go. So that's the first one. Load another screw. Here.
उल्टा वजन है का?
True. Keep things ready, please. Okay.
Connect us to OT3, please. OT3. Yes.
Hello.
Hello.
Hello, yes, sir. Dr. Ramesh, sir, you're not audible, sir.
Hello.
Yes, sir.
Yeah, can you hear me now?
Yes.
As you can see, we have fixed our frontal segment to the craniotomy segment here.
Yes.
And as you can see, this modified orbital frontal segment is in place now. There is an advancement of about 1 centimeter, as can be seen here at the nasofrontal junction also, and on this side also. And you can see that the contour of the forehead on both sides is symmetrical now.
Right.
Right? The part which was depressed has been placed posteriorly. So this will be covered in the hair and it will not be visible.
Right.
Okay, thank you. We have also done the barrel stowing here for the Scaphus felly. So yeah, he is going to show you now.
Strong नहीं है, बड़ा.
Yeah, can you see?
Yes, sir.
The barrel stowing has been done. This is to expand the skull in the horizontal direction. And we have one piece of bone which we are going to place between these two things to stabilize the two bones on either side of the midline.
Yes, sir.
Okay.
Any questions for Dr. Sharma, please? Okay, sir. Thank you.
Okay.
Connect us to OT4, please. OT4.
Hello. This is the posterior craniotomy segment.
Yes, sir.
Okay. This is my new forehead.
Yes.
Okay. It came little unequal on this side. This bone piece will remove it and use it somewhere else. And this entire assembly will come here.
Right, sir.
As a new forehead. You can see that there is so much amount of overlap.
Yes.
That keeps the bone flaps in position with multiple features. And the orbital bundle. I will show you the table work where this bindu will be opened and will be fixed here.
Right.
Okay. So that table work I will show you.
Yes.
दोन होल जाणार ना इथे पॅरलल मला एकदा ते लावून पॅटर्न मला रिकॉर्ड बघायचे तुम्ही करा तिथे तुम्ही मी टेबल वर करतो चलो इसका give me table here This camera will be here now. It on करो. I require a drink. Stool दे दे सर. चलो कटन दे दो. कैमरा फोकस करो. Because one vendor you find. You see, this is what opened up. Incorporate करवा लगे. Yeah. बना के दूसरे. बना. Okay. One more. मैं 20 PDF मंगा के दूँगा 20 ले लो 20 PDF है ना उधर है ना तो नहीं थोड़ी स्ट्रेंथ है ना चलो PDF वन नीडल होल्डर गोल्डन हैंडल नीडल होल्डर क्या हुआ? हाँ ठीक है ना, नहीं ना नीडल है ना, अरे खराब हो गया, दूसरा दे दो 2 रुपये। चूड़ा डाल, चूड़ा डाल, बाजू में रखो इस तरह। से बात नहीं कर। Try to keep the knots inside. Okay, now we can say that. Now the other case is there. मेरे को अभी डाला नहीं, अभी देखिए नीचे आया। बड़ी चीज़ों का बनाना चाहिए। The marking there. Marking. मेरे इसमें पेंसिल है, पेंसिल है, मैं मार्कुन टाप दिया, मार्कुन सेपरेट हुई। ध्यान देता हूँ, मार्क करने के लिए। मार्किंग करूँगा। तो मार्कुन जैसे करते हैं, ऊपर अभी उधर का ले दो, इधर का ले दो। चलो इधर कौन आ रहा है? स्ट्रॉन्ग आर्टिस्ट। अभी मेरे को एक राउंड बॉल लगेगा थोड़ा बॉल करने के लिए। बॉल निकला था। चलो बॉल मेकर दे दो, बॉल मेकर बॉल मेकर तो वो दे दो, बॉल करने है इसमें पानी It's a number one previous level. Number one. Other. Assembly.
Hello? Yeah, anybody there in the hall? Hello? Anybody in the hall?
Yeah, we are all here.
Yeah, okay. So just before we are going to close, before we'll just show you, this is the final shape. Please don't look beyond this because posteriorly we have kept the depressed segment. So this is the recreated forehead and the frontal bendo and the frontoorbital segment. And if I can show you, when I redrape it like that, the forehead looks symmetrical now. Okay? Hello?
Yeah, we see it.
Okay, all right. So we are going to close.
Okay.
Thank you.
Thank you.
प्रिंट रखेंगे बाद में रखेंगे इसके बाद ठीक है वो खाने का बाइट ज्यादा बड़ा होगा तो फिर बोला नहीं गया तब तक फिर जब तक खत्म हो गया बंद हो गया ऑन है
inside. Inside. Lower end of basically the common sequence.
देखो जरीसा 44 connect the audio to 44. Audio 44.
Hello.
Yes, sir.
So this is how we have prepared the forehead.
Right.
I'll just show you the inside one. The orbital band is fixed under the surface of the forehead complex.
Very
It has taken the curvature of the new forehead.
Yes.
Then it is placed here.
Yes.
Exactly. You can see there is a bone-to-bone contact.
Right, sir.
You don't require plates and screws to fix this.
Right.
Just where through wire PDA sutures are sufficient.
Thank you, sir. Any questions for the
Now the cosmetic correction, you can see.
Yes, sir.
Now we will come back to you at the time of fixation.
Right, sir. Take us to OT1. It's also almost done. Take us to OT1.
OT1 connected.
Dr. Suhas, sir. I think they're also closing up. OT1, Dr. Suhas. Lectures uploaded in a center. Next, Dr.
Hear me?
Yes, sir.
Yeah, see, the bandu is done, the frontal bone is shaped.
Right.
I'm fixing the frontal bone. I need a better needle holder, please.
Then light on कर दीजिए.
This is not holding. Can you take that? Can you hear me?
Yes, sir.
Yeah. I don't know if you can see. Just give me a minute. I will cut this. Yeah. Just give me a minute. I will show you where we are. Seriously. So just to give you an idea, we have that is our new bandu and the frontal flap.
Right.
The lateral rim is corrected now, and the frontal flap has moved medially by 2 centimeters to the midline.
Right.
So this margin was 2 centimeters away. That means the forehead prominence also has come medially by 2 centimeters. Even the other side is also corrected. If I can just show you now, if your measurements are accurate with very minor, drilling, you can get your forehead flaps to sit like that onto the bandu, and you get a new forehead like that. So once this is done, we can go and fix the bandu and the forehead flaps back on, and then rearrange the other pieces, and then we will be done.
Yes.
I hope you can see that.
Yes, sir. We're seeing that.
That's the curve that you get. That's yeah.
Right.
You get a nice curve there, natural kind of curve.
Right.
Because you're using native bone there, like that.
Right.
Yeah.
Sorry? Take only 1 and 4 on either side and let the
That when we fix it, we can advance it. Yeah.
1 and 4 run on the sides.
And if it is deficient, we can always overlay a small piece of bone.
Cut off the audio now. We have Dr. Aja with us for the talk right now. We should do the. Bring next week to partnership with We want it. You can plug and you can have all the text. So we are ready. Sir, yes.
We start now.
Audio only stop करिए.
Should I start?
Yes.
Okay, good. And good afternoon. I would like to thank Dr. Deepak Gupta for the nice invitation. It's always a big pleasure to be here. This beautiful country, and especially attend to this exciting meeting and to talk about an exciting topic like coronary craniosynostosis. What deferred the pediatric neurosurgeon is his work with a special case like hydrocephalus, spinal dysgraphism, and craniosynostosis. Craniosynostosis is characterized by the presence of one or more suture undergoing premature ossification that are expressed through craniofacial deformity. The incidence is 1 to 2,500 live births with 1 to 2 recurrent risk. The etiology of many cases has not been clarified, but some etiological agents are already known. The genetic or epigenetic in 30% of syndromic form and the 2 and 5% in non-syndromic form. And there are positive family story, like here in this picture. This is the grandmother, mother, and the son. In 2% of sagittal, and in 10% of coronal and metopic. And we know that many environmental factors like fetal constraints and unhealthy maternal
lifestyle has a strong influence of the occurrence of craniosynostosis. The craniosynostosis, in general, we can classify it in primary craniosynostosis and secondary craniosynostosis. And we can classify the primary craniosynostosis in non-syndromic and in syndromic form. And here you can see the classification from non-syndromic form. This is the most common form of craniosynostosis that we classify in single, in simple, and in multiple. The simple one is the most common, and in this case, the most common is the scapulocephaly. In the higher case, the posterior plagiocephaly. We have many cases of multiple non-syndromic craniosynostosis, but the most common is the brachiocephaly. And here you can see in a graphic way the different form of the simple craniosynostosis. Here you have a normal skull. Here we have a brachycephaly, scapulocephaly, trigonocephaly, and a plagiocephaly with the respective affected suture. The craniosynostosis, the syndromic craniosynostosis, we have here some picture like this occlusion, the upper, and this Pfeiffer case. This is very complex craniosynostosis. And if we talk about the secondary craniosynostosis, we have the synostosis post shunt implantation, follow over drainage, and we also have craniosynostosis related with brain atrophy, related to severe traumatic brain injury and infection, like which for us in Brazil is a normal problem, is Zika virus gestational infection. After this brief introduction, we can talk about the issue of this conference. The anterior plagiocephaly is the second most common type of simple craniosynostosis. The unilateral form is 4 to 7 times more frequent than the bilateral, the brachiocephaly. The right side involvement is 2 times more committed than the left side. The occurrence in the female gender is twice as high as in the male. This sporadic form is about 61%, and the syndromic form is about 39%. Clinically, characterized by early unilateral fusion of the coronal suture, the coronal suture profile may be palpable, and sometimes we can see very clear the dysostosis. The triangular shape of the anterior fontanelle, a symmetric skull and face with unilateral flattening of the forehead, shallow orbit, supraorbital ridge is posteriorly located and backward and upward. Bulging of the contralateral hemiforehead, shortening ipsilateral temporal fossa. Here, anteriorly, displaced, and the nasal pyramid and the chin joint of the mandible are deviated contralaterally. That's really the big challenge in the plagiocephaly is the correction of this nose scoliosis. But we have also ocular anomaly, globe asymmetry, mild globe protrusion, hypertelorism, variable degree of strabismus and astigmatism, abnormal acuity and asymmetric visual field. In more severe cases, could be involved calvarium, skull base, craniovertebral junction, and C1. Torticollis and abnormal position of the head. And developmental problems may be present in 10 to 61% of the cases. There are a classification of anterior plagiocephaly regarding to the extension of the deformity. And we have this type 1 with unilateral flattening of the frontal bone and elevation of the superior orbital ridge. That is the light form. This is a middle form, type 2, that we can divide in type 2A and type 2B, with frontal and orbital anomalies are accompanied by contralateral deviation of the nasal pyramid and homolateral anterior displacement of the petrous bone, and the type 3 is more complex with severe deviation of the sphenobasilar bone with secondary asymmetry of the craniovertebral junction. And the same patient can progress from one classification to another, as you can see in this photo, in this picture. Yeah, it's a patient in young time. Then later, you see here is classified type 1, and here is classified as type 2A, because the nose deviation. This classification is very useful because we can establish a relationship between classification and the functional and the aesthetic postoperative outcome. The type 1 and type 2A, we can expect a good prognosis, and the type 2B and type 3, we can expect a bad prognosis. The result is not very good. And if you talk about the diagnosis, we have the standard plane radiography, CCT with 3D reconstruction, and NMR are the diagnostic tools and are very important for the surgical planning. That means this radiological study is very important not only for the diagnosis but the surgical planning. When we have the bilateral coronary synostosis, we have a brachycephaly. And here you can see the clinical findings in the brachycephaly is a bicoronal enlargement, occipital and anterior vertex scaling, tuchicephaly, anteroposterior shortening, shortened anterior fossa and widened and deep middle fossa, hypertelorism, intracranial hypertension, and you can find synostosis in sutures of the base of the skull, like sphenofrontal, sphenoethmoidal, sphenozygomatica, and the typical face of eyes of devil, as you can see here. And here you have brachycephaly, the CT, and the 3D reconstruction, the absence of the coronal suture, and the typical aspect in the CCT. And here you see the differential diagnosis of plagiocephaly. First, the cranial asymmetry acquired in utero at birth or in the early postnatal period. That could be transitional or definitive. And the deformational plagiocephaly. The deformational plagiocephaly is more common as the true plagiocephaly. We find in 20 to 30% of these births. And here you can see a very interesting skull. This is a South America Peruvian archaeological piece in the Paracas culture. The indigenous put bands in the heads of the children for which this strange format. Why the indication of surgery? The indication is only an aesthetic issue or also functional. The study revealed the presence of intracranial hypertension and brain compression. The SPECT and the transcranial Doppler, you can see cerebral hypoperfusion below stenosis. You can find irritative syndrome, convulsion, visual disturbance with decreased visual acuity, papilledema, diplopia, and strabismus. The intracranial hypertension is present in the simple synostosis in between 2 to 17% of cases, in multiple synostosis in 47%, papilledema is present in 27%. In some cases, we can find hydrocephalus patients, and is associated with this intracranial, this chronic intracranial hypertension. We have the deterioration of the intellect or intellectual retardation. The aesthetic consideration are also very important. If you remember that the craniofacial dysmorphism may develop disorder of psychosocial development, personality disorder, and in extreme depression case also suicide. If we talk about surgical technique, the classical approach is the fronto-orbital advancement. I will show more detail in the second part of my talk about this approach. We have adopted this approach, this strip craniectomy, in light case without commitment of the orbit. But this approach has some limitation. Does not address the stenosis of the skull-based sutures, lack of correction of the retraction of the orbit, and high recurrence rates. Another approach is the bone distractor, interne and externe. It's very useful, especially in case of facial advancement is necessary. But they have limitation, needs 2 or more surgery, need close care, lung hospitalization, sometimes happiness distortion or dislocation of the device, infection, and high cost. The endoscope coronal suturectomy, we had a small experience with this approach. We had only 5 cases, and in 3 cases, a second approach was necessary. is very limited to young children, need to orthotic helmets, and because these helmets is the cost very high, and for a country like Brazil is normal, impossible to use in the public hospital. And the spring-mediated cranioplasty. It is minimal invasive surgical technique with some limitation, like doubtful distraction, limitation of age, needs a secondary surgery and some complications like extrusion of the steel, dural lesion, and infection. Independent of the used technique, some complications should be remembered and avoided, especially in reconstructive surgery, like the transoperative blood loss, gas embolism, especially if you have lesion in the sagittal sinus, injuries of the dura mater, increased extradural space with risk of epidural hematomas, post-operative blood loss, especially if you forget the drainage, the open drainage, migration of the fixation material, infections, hydrocephalus pre and post-operative, and abnormal growth of the skull post-correction or recurrence of craniosynostosis that determine an indication of a health operation. And here I show you our small experience. We have two series. First, this is a series from 1992 to 2005. We have 85 cases. The most of these, like everywhere, are scaphocephaly, and the plagiocephaly are the second most common case in this time. And another series, 56 cases between 2006 and 2016. We have the same, the prevalence of scaphocephaly. The plagiocephaly is the second most common synostosis in our department. And now I show you some of our case. This is a plagiocephaly. In this case, the compromission of orbita was very light. So we decide about this approach without front orbital advancement, and we had a good result. If you see here, here is another case. The patient has this strabismus. This strabismus is correct, but persists the nasal scoliosis. Here we have another case with the result. This is very difficult if you have a patient, older patient. The result is not very good. But here you have the preoperative picture, CT, and the postoperative CT. And another case, the plagiocephaly. This is the preoperative picture. With the characteristic three-dimensional CT and the post-operative which would reduce. So, to conclusion, plagiocephaly may be present in different degrees of deformity, often extending to the skull base. And the surgical approach depends on the type of deformity. This is very important. The frontoorbital advancement is the classic approach. The age of the patient and the severity of the deformity interfere in the final result, either functional or aesthetic. Now we going quickly to the second part. So, the second part is the frontoorbital advancement, how we do it. The frontoorbital advancement may be indicated in different cases of craniosynostosis, simple, multiple, or syndromic, which are accompanied by facial deformity and require orbital decompression. There are many variations of the technique according to the craniofacial deformity. You can see in the literature or in books different technique of frontoorbital advancement. I show you step by step one of our case of brachycephaly that we did the frontoorbital advancement. The patient is positioned supine. The hair is shaved only on the incision marking. The application of eye ointment. We never do the tassographie. Never do. I think it's not necessary if you put the ointment. The face and scalp are draped into the surgical field so that the orbits can be checked during the operation. This is important. And the big coronal incision with monopolar needle extend through the guylia. Yeah, we normally use this monopolar needle from the strike. This is very useful because we try to don't have blood loss. This is the objective from this monopolar needle. Bipolar coagulation. Yeah. Then you can see here the scalp flap elevation. This is normal. Subgaleal dissection carried out on the scalp flap, reflected forward down to the orbital rims. Dissection of the anterior fontanella if exists, but take care with sagittal sinus. This is very important. Yeah, very important. Because this, especially the small children, they don't support blood loss. Don't support blood loss. Yeah, this is very important. Yeah, the whole surgery must be clear without blood loss. Lateral dissection of the pericranium together with the temporal muscle. So with that, we avoid the temporal muscle atrophy. Dissection of zygoma if periorbital dissection. We do the bifrontal craniotomy behind the coronary suture with high-speed craniotomy. Yeah, normally we take out the dysostosis, yeah? The bone flap elevation, hemostasis with Surgicel and bone wax, the bone flap reshaping. You see here the picture. The epidural dissection is carried down into both middle fossa and anterior part of the anterior fossa. protecting with cotton strips. You see here, we put this cotton strip to protect the dura mater and protect the orbiter too. This is facilitate that make easy to do the craniotomy and the orbitotomy. Cut of supraorbital bundle with piezosole. Here is the piece of piezosole. Hemostasis with Bonivax and duroplasty, if necessary, of course. And we do carefully inspection. If we have, we look for dura lesion. Supraorbital bundle reshaping. The sphenoid wing should be removed toward the anterior clinoid, and the reconstructive part of the operation with absorber plates and screw must be individualized to the child's deformity. Sometimes we don't have these absorber plates, then we use bicule. If we don't have, because in Brazil, not always we have these absorber plates because the cost is very high. And finally, implant of subgaleal intermittent drainage. But always we put drainage, but we left the drainage closed. We open every hour for 5-10 minutes, then close to avoid the blood loss, the postoperative blood loss, and observe the aesthetic result before the incision closure. And we have depends of the case, we have a different form of incision closure. Well, complication is possible. Bleeding, transoperatoric from operative field, from venous sinus lesion, and postoperatoric. Anterior cranial fossa nasal cavity communication. This is a big problem sometimes because we have the CSF leakage, infection, abscess, meningitis. In very, very, very complicated case, we can have osteomyelitis. This is a big problem. Fixation material displacement, necrosis in the incision area. If we do excessive advancement, we close with tension, and it can happen with this necrosis, infection, abnormal bone growth, and recurrence of the craniosynostosis, especially if you have a very young patient. To conclusion, the front orbital advancement is a very useful technique in the treatment of craniosynostosis that require an experienced team formed by anesthesiologists, plastic surgeons, and pediatric neurosurgeons. Thank you very much. So, any questions or comments?
Lights on, lights on.
Please forgive me my Brazilian English.
No, it was a perfect English and a good lecture. We thoroughly enjoyed your talk. Regarding the helmets, we in entire country except for 1 or 2 segments, we also don't use helmets. A, because of expenses, and B, because the children usually present quite late. And helmet therapy is usually very much indicated for patients who are
operated very early, being subjected to endoscopic procedures. So we also don't use much. But nowadays, yesterday I talked about the 3D technology. So there are people who are making very cost-effective helmets, customized helmets to the children. So in case Brazil needs, India could export helmets to this.
Okay. Thank you.
We'll work it out. It will not be very expensive.
What is
approximately $200-300, I would say.
$300 is not a small money.
Our experience with helmets is very small because they cost so only the private patient can have this helmet. We really don't use in the public hospital.
Arthur, in your country, do you do these surgeries alone, or you do it with your maxillofacial plastic surgery folks?
The simple craniosynostosis like sagittal, scapocephaly, plagiocephaly, and sometimes the brachycephaly we do alone without the plastic surgery. But the complex craniosynostosis normally we do together with the plastic surgery, and sometimes do the plastic surgery alone without participation of neurosurgeon.
Are there any other questions from Professor Arthur, from anybody?
What is, do you have lost any patient in your experience? Anybody has not made it or died of anesthesia surgery complications?
Intraoperative mortality.
Not in the postoperative, intraoperative.
Yes. Okay. Our experiences, we don't have mortality, intraoperative or postoperative mortality. Yeah. I think the trick in the craniosynostosis is the preoperative planning. I always say for my resident, must planning, study the picture. Planning is very important. If you start surgery and you don't know really what do you need to do, then you have complication. That is the problem.
What's about sagittal sinus fear, venous air embolism?
No case. No case. Oh, that's true. No case. We don't have case. Yeah. Because if you do the craniotomy, immediately we put surgical above, over the sagittal sinus, and we put a wet towel, so we can work very safe.
Thank you.
Thank you very much.
Thank you.
Just a brief announcement. The dinner today will be 7:30 onwards in Faculty Club lawns, which is just few meters walk away near the director's office. And and because we have called upon some children, so it will be a pure non-alcoholic dinner. So those of you want some alcohol, please come prepared. Then no alcohol will be served in the dinner. I'm sorry for that.
All three OTs are finished. बिल्कुल सही है। वहाँ पे बनके करिए। नहीं वो किसी के बन के आएंगे।
शनिवार को बच्चों को we already replaced all the new pieces which are shifted from back in front. This is the front forehead bandu. The forehead part of the frontal cranium divided into two parts. We fix it here and one here, and there is one small piece is there which we are going to place it here. One we are going to place it here. पानी पानी मार पानी मार पानी मार पानी
Next up.
Yes, sir.
Yeah, I'm Dr. Shimozu from Japan. I'm very thanks to everybody to call me here. I'm very proud. This is my privilege. Today I'm talking to mild trigonocephaly. It's very challenging. Okay? I invite you to a new world. Okay. Anybody hear about the mirror neurons? Anybody know? If somebody knows, raise a hand. A neurosurgeon must know from now. Okay. Today's keyword, the mirror neuron. It was found by a psychologist in Italy 20 years ago. And this discovery is the good value as like the Nobel Prize. Typical trigonocephaly, the physical examination found, you can find the following. The keel-shaped deformity of the forehead. Here is the front of the ship. The second metopic ridge. Metopic ridge. The typical one you can see the inspection by the inspection. Number 3 is the compression of the temples, bilateral. Number 4 is the hypothyroidism. Mild trigonocephaly. You can find the same thing. However, the forehead is just round, like a heel shape. I named the heel shape deformity. The characteristics of the findings of the CT and MRI, the metopic ridge, and smaller anterior area, the smaller anterior fossa, the abnormally wide sphenoid ridge. This is very important to me. Digital markings you can see on the 3D CT, and if we have any kind of abnormality on MRI, we don't do surgery. On MRI, the no abnormality found. Fine. And then without the frontal lobes look like smaller. Mild trigonocephaly, it's troublesome. This is a Cohen's textbook. It's very famous textbook for the Craniosynostosis. Everybody knows about this book. In this book, said that mild trigonocephaly is no such indication and never present symptoms. Those written in the textbook. However, there is no evidence. Most people ask me to make evidence medicine. but these are not. I am challenged to this. Advancing in medicine is the number one. Firstly, the personal experience. Secondly, the mechanism. Why? What? And third one is quantification. This is just a statistics. And after this, we could say the evidence-based medicine are finished. Firstly, I'm going to present firstly the personal experiences. The first case and the third case. Both of them have their quite hyperactivity. And his surgery was done in 1994, and this one in 1996. And after surgery, both of them had marked improvement. And several cases were carried out for purely cosmetic. However, all of their clinical symptoms were improved after surgery. I was curiously wondering about this fact related to the surgery or not. And the sixth case was carried out various examinations, including psychological tests, in order to do the surgery prospectively to improve the clinical symptoms. This is a 3-year-old girl, unable to walk. She could not speak at all, and she was diagnosed as autism. And this picture, this is after couple of months, I think. You can see the change. She was markedly improved. At 6 years old, she got into the normal class, and at 18 years old, she graduated from regular high school and working. And evidence of this case convinced me that surgery to the mild diagnostic influence something good. After that, I had more than 500 cases now. Have been done with many process cooperations. The result of these cases will be presented with several cases on videos. Interesting past history. Most of patients grew up without symptoms until they are age 1.5 years old. Most of them. The regression phenomenon in the textbook of autism, the regression phenomenon is usual. It's saying that. However, to me, if you see the regression in the child, it's great things for this girl, this patient, the patient addresses. I'm living in Okinawa. It's a very southern part of Japan, and very rural island. Patient comes all over Japan, not only but also the foreign country. The age distribution and sex. The total 518 patients in male dominant. And I doing the surgery up to 8 years old. Now we're showing them with several cases on video. This is a 4-year-old boy. He has only a few words, hyperactive, and difficult to play with other children, and a lot of group poor understanding. He also had the diagnosis of autism. Now I'm asking, how old are you? You can answer 4 years old. 4 years old. Now, keep asking, say egg. He could not say egg. Also, 9 months to 2 years. At the graduation ceremony, he's speaking a long sentences. He's saying the player of soccer, football. A couple years later, he's going home with other children, and no more to call his autism. There are a lot of videos making trouble sometimes. Four-year-old boy, no meaningful word, and just doing this. All day long.
똑똑하네요. 이제만 그냥 비아노를 꺼내는 친구지만
Also 4 months. He's speaking now. Also 5 years, he's in a special class. However, he has only had trouble with speaking. And his father complaining that he's very smart, nothing trouble with except the speaking. And next case of 3 years and 9 months old girl, she has no meaningful walk, unsteady walk, and on the physical examination, you can find the hypotonic, and you can see the very small fossa and some digital markings. Just before surgery. She's very unsteady walk. Couple years later, she came back walk. Now, next case, 5 years ago, only walk. She has a symptoms of panics and sleep disturbance and self-mutilation. This is continued more than 1 hour. She has the difficulty to sleep. This is before surgery. She always hitting the head. Almost 3 years at school. She could went to school. She could go to school in the special class. Also 5 years playing piano and explaining how she could. And she has no trouble with conversation in daily life. And she's speaking very good. And we have self-mutilation. Head banging is most common. Sometimes you can see this kind of self-mutilation. Night terror. We had several times do this during night, one night. And this continue every night, every single night. We have night terror. So his father, having trouble to get sleep. And before surgery, he had this kind of a symptom, and also 2 years almost normal. He's in a normal school. Why we have the night terror? Probably when you get to sleep, the A waves and B waves coming up. Probably that's why they will have the night terror. Indication of surgery. The patient should have the clinical symptoms. This is the most important. On 3D CT, the metapic ridge should be there. The small frontal area and the anterior fossa. Abnormally wide sphenoid ridge. The marked distal marking. No brain abnormality on MRI. Surgery. After the bilateral craniotomy, and we take out the orbital bar in one piece, and then removing the sphenoid rings and ridge to the meningeorbital band. We taking the major wing and lesser wing too. I think the sphenoid wing is most important to giving the symptoms to the children. Cutting light to make the bar. You cutting like that, My patient is older than 4 years, or half of them. And so we have the anterior frontal sinus. So to avoid the open the frontal sinus, so cutting like that. This is the result, the symptoms. Various symptoms here. The percentage of the improved rate is, I think, everything is good result. And I divided in 3 groups. Quite improved, 270 cases and 52%. Among this, 70 cases in regular school. Slightly improved, 223, 43%. So that total 95% patient having some kind of improvement. The secondary, the mechanism. You see the very small frontal area and the anterior fossa. After surgery, increase the size of the frontal area and I increase the volume. I increase the size of the anterior fossa. Bone release is so fast, so we have to take the bone out very much. Sufficient decompression should be done for treatment of the craniosynostosis. This is my my thought. You can see the having the orbital, roof of the orbital, and it grows. This is the 6 months after. You can see the quite a bit of bone degeneration. You can notice that. On MRI, this is pre-op. This is post-op. No need to explain. Change of the digital markings. Pre-op, post-op. The decreasing the digital markings are modified. So that means the decreasing ICP. We measuring by Camino's sensor. After 50, number 50, we measuring the ICP in each cases, almost each cases, and 93.5% patient having the increased ICP. I think the more than 11 millimeter mercury we call the increased intercranial pressure. And this is the spectrum. The preoperative findings, and we can see the improvement of CBF. However, the results are qualitative. So that the next will be a PET. We're planning to do PET in the this year. Now, another one. What do you think this is the spinal ridge? However, somebody doing the aneurysm surgery, what do you think this is? What do you think this spinal ridge? Don't you think it's abnormally white? Yeah. What do you have here? On the left side, broad about 44, 45. And then this area we call pars pectoralis. Here, the mirror neuron exists. This area. This sphenoid bone, sphenoid ridge, sticking into this area. So it might disturb the mirror neuron. And what function of the mirror neuron working here? If somebody laughing, you laugh, okay? So your mirror neuron is normal. And to the baby, you laughing to the baby, and baby notice your baby suck, and that kind of thing. And somebody swinging the golf club on the station, platform of the station. You're singing the golf club, isn't it? That kind of thing, the mirror neurons do it. And then if your professor is hungry, you cannot be laugh, right? So that kind of things, so mirror neuron does it. The autism, they still need to be proved, not enough to produce the autism. This is the abnormal sphenoid ridge. You can see the compressing of the parts of pectoralis. And after surgery, it's released somewhat. And patient with Asperger syndrome showing decreased CBF in the parts of pectoralis by functional MRI. That's why the function of mirror neurons decreasing. A lot of paper coming from psychologist department of UCLA. And now, this is the scaphocephaly. You can see the abnormal sphenoid ridge before surgery. And then I'm focusing now every craniosynostosis to see the sphenoid ridge, every single case. And in this case, the quite a bit of wide sphenoid ridge was found. Scaphocephaly, brachiocephaly, brachiocephaly, every case can find the abnormal sphenoid ridge. Mechanism. A lot of abnormal things were found in the mild craniocephaly. These were estimated to have contributed to the worsening of the symptoms. Lastly, quantification. First study, my study already published in journal 2015 and last year, no, 2 years ago, yeah, 2 years ago. Okay, now DQ, the developmental content. So just see, this kind of thing is making more people. So I go fast, Just see the result. Just see the see the double stars, in DQ. You can see the double stars around. And language. Also 6 months, you can see the double stars. And pulse. The test for autism spectrum. This is coming down. This is the good decreasing pointer better result. So 6 months or so, quite a bit good result. The child behavior checklist. This is very usually ordinarily used in United States, behavior checklist. And several scales exist. And externalization, this is the towards the hyperactive, and you see the stars here, and program scale also. And the last 4 years, we had the cooperative study with Juntendo University, and that was the 4 points, 3 months, just before operation, for 3 months post-op, and the other, I'm sorry, this is the 6 months, 6 months post-op. This is a 4 point. We did 4 different psychological tests, and between this, we said the natural history. Compared to this one to post-op and the post-op 6 months, we did it, and we call this self-control study. The ethic thinking, I cannot do the complete control test. You know, somebody patient comes to me, they want to get improvement, you know, and I cannot divide it. You do surgery, you cannot do you do surgery. I just cannot. So we did a self-control study. Totally DQ. The P1 is the natural history. The post-operative, this is a 3 months post-op. It's very nice, significant. And then this is autism, also. Nice number here. And this is a language, quite a bit good study. And another study. This was done 3 years ago. PQL of the patient over 10 years post-op. After surgery, every scale is getting better. There are another programs coming up. Number one, so many patients I can find. And number two, the brothers and sisters are so many. So we and the bones are so dominant that it is a hereditary. Now we DNA analysis is proceeding. This is 4 brothers. Okinawa. The 3 brothers and sisters. Problem 3, the associated microcephaly. The microcephaly usually, if you see the CT or MRI, you can see the very atrophic brain. However, my patient did not have any abnormal findings on MRI. And however, the patient having the mild craniocephaly. And that kind of patient, I was, first time I was so hesitant to do, but the family is strongly asking me to do surgery, and I have done the surgery for microcephaly. Now about 16 cases done. And this is the boy, 1 year, cannot have the head control. And after 6 months, you can stand with support and head control is completed. And then he was walking. And the rare form of the craniosynostosis, metopic ridges, metopic suture and central suture is closed. This was not on the textbook. So I found this 35 cases and I submitted now. I willing to accept. Conclusion. The man prognostically, the with symptoms might be treatable. The second, to make DBM cooperative study should be done more. Thank you very much. I have your folders here. This is the Ganapati in ISP. As you hear my English, I used to speak English very well. I spent in Chicago for 5 years. So, however, today my English becoming down. Please ask me shortly and clearly. Okay? That's it.
Can I ask a question?
Yes.
You mentioned the prominence of the sphenoid ridge. The sphenoid ridge, it is very prominent in metopic synostosis. So, do you recommend shaving it off or?
Just kill the ring. All the time, you can see the anterior cranium. So that sphenoid ridge making the later on the cognitive disorder. After taking after removing the sphenoid ridge, the brain like what do you say, squeezing.
I mean, trigonocephaly, this is a very interesting issue in the craniosynostosis. And I said in my talk something wrong. I said that the anterior plagiocephaly is the second type of craniosynostosis. The second most common type of craniosynostosis. If I say the truth, the second type, most common type of craniosynostosis is the trigonocephaly. Yes, that's true, no? Yeah. The problem is we operate more anterior plagiocephaly than trigonocephaly. One difficult point is how can I approach the parents and convince the parents that if the child has a behavior disorder, that we can resolve this problem with a surgery. This is very difficult, no? Yeah, we will have problem with not only with the parents but the pediatric neurologist too, but perhaps the pediatrician too. Nobody accepts it. Yeah, this is a. So I think we need more information. We need perhaps a cooperative study, yeah, to confirm that some autism case or some other behavioral disorder have a close relationship with the craniosynostosis like trigonocephaly.
Thank you. Last 20 years, they are famous doctors. Every famous doctor saying like that. Every famous doctor. I present this ISP they one doctor pushing me, just we always fighting, they throw out to the platform. I would say this is my experience. See? And then in Japan, influencing a little bit to the two places, three places doing this surgery. However, the foreign company did not doing this surgery because of the textbook saying like that. So I said, the patient cannot wait, they are children. So after you hear my talk, you inform to the pediatrician or pediatric neurologist. Just feel this metaphoric reach. You can feel, you cannot diagnose the inspection. However, if you feel this, you can find the this findings. And then go to the 3D CT, and you can find the metaphoric and the mark digital markings. If you see the digital markings, what do you think? Because of the, people say to me, because prognostically having the digital markings, and they say this is normal. How could you say that? I won't say.
Any child whom you operated who did not improve cognitively after the surgery?
Yes. Some of the, if before surgery, the patient having a very high visual correction, or the patient age over 7 or over. And then severe autism. They never had. So 5%. I do the every patient. That's why my result is 5%. Changed. But if I choose the patient, result, I cannot do that. I cannot do that. If I see those kinds of findings, I have to do it. I'm a neurosurgeon. The patient having increased intraocular pressure. I have to do the surgery.
Have you measured ICP in any of these patients? Do they have raised ICP? Have you measured?
My rate at the previous stage, making more. So, it's only 10-15 minutes. But if you're taking the cranial, child product cranial, and the field break, you can feel the high pressure there. You can, you're neurosurgeon. So, if you feel the brain, you can say this patient having the high pressure. Yeah. So before taking the ball, we make measuring. It's so expensive. Sensors. Let's say 90,000 yen. 900,000. So I spent a lot of money.
All the patient had raised ICP screens.
Maybe 4% patient having the high ICP. Problem is the patient having the under 10 millimeter mercury. Some of them get better. So,
Not interrupt, sir. Before CT scan, I think we had seen compressing the
other institutes like Juntendo and another place, they do the measure overnight of the measuring the SUP. And they get the proton wave, the milli waves, and something like that, and they do the social. As I say, my patient having the, over 30 millimeter mercury, and then you get better. So I could not divide it by ICP. I think. But including ICP, as a neurosurgeon, you have to do something.
But when to evaluate, sir, if a patient 3 years old comes with autism diagnosis, what way we have to evaluate?
But the patient having symptoms.
He may be having some
No.
atopic
But the thing is, the 10% people having the ridge without symptoms, they go lower. That's why, many famous neurosurgeon brain, many people having just ridge, they are not my trigonocephaly. But I am dealing with patient with, symptoms. So if you have patient having this, any kind of clinical symptoms, and you just go evaluation.
Now I call upon Dr. Chidambaram to continue this talk.
I have a paper, maybe several papers I bring to her. So if somebody wants to paper, they ask them. Okay. Thank you very much.
Shweta, what talk?
Both, sir? I'd like to hear both.
You want to hear both?
Yes.
Are you sure?
Yes.
Okay.
Go on.
You asked for it. Okay. Fine. Now, okay. Now, craniosynostosis, by now you would have realized it's not a simple problem. It's a very complicated issue, and in that complicated issue, there are more complicated issues. So we'll look at some of the critical aspects of these problems. So this will be the outline of my talk, and these are the things I'm going to consider in this talk. Okay, so some are syndromic, some are non-syndromic. We have polystructural cynostosis, which are not part of the syndrome, like the child that was operated today. The child has coronal and sagittal, and that doesn't fit into any syndrome. And there is a smooth transition. There are gray areas between the syndromic and the non-syndromic varieties, and sometimes it can be very difficult to diagnose that. number of issues are there, and these do not all present at one time. They come at different times in the child's life. So what are the problems we have to discuss with the anesthetist? What are the problems we have to face when the child is being anesthetized? See, you take a syndrome like let us say Crouzon or APER or worse, Picker syndrome. There's a whole lot of issues involved in that. Different parts of the body are involved. So the anesthetist has got to be very careful, and you have to be very careful in talking to the anesthetist, discussing with the anesthetist. Some of the common problems are a small, difficult airway. You may not be able to intubate the child. I'll show you some examples. Blood loss. The greater the worse the stenosis, the greater the blood loss. Hypothermia, long surgery, prolonged surgery, very high incidence of hypothermia. My anesthetist says, if I have to have one thing, that would be patient warmth. Okay? Air embolism, I'll talk about that. There's hypoplasia of the face, which again compounds the problem of small airway. They're all mouth breathers. I'll show you pictures of that. And OSAS, I'll talk about OSAS also. Air embolism, surprisingly, is seen in 2/3 of the children who undergo craniofacial surgery. Some of them, most of them are clinically insignificant. But some of them are clinically significant, and I have lost a child on the table due to air embolism. When there's massive air embolism in the heart, the blood is just like the froth you get in your beer. There is nothing you can do about it. No amount of blood transfusion fluids is going to help. You may have a central line, put it in the right atrium, and you may aspirate. May help, but usually it doesn't help when there's just froth in the atrium. And this usually happens when the bone flap is being dissected because the vessels in the bone do not collapse, they are still patent. They can suck up air. And again, when the dural sinuses are dissected, and that's an example where we had air embolism. Okay, this is a very, very complicated and a very, very tricky issue. Hydrocephalus in craniosynostosis. We don't know why the exact incidence. It's probably 4%. 12% is an overestimate because nobody has really defined what hydrocephalus is in craniosynostosis. Some children may have mild ventriculomegaly and they may be dumped as hydrocephalus. Now, it's very high in the syndromic varieties, particularly in Crouzon and APER syndrome. And even if there's Chiari, okay, and mild ventriculomegaly, it compounds the issue, it makes the issue worse, whether you don't know whether it is hydrocephalus causing Chiari or craniosynostosis causing Chiari or Chiari causing hydrocephalus. I mean, it's anybody's guess at that point. But the rough incidence is somewhere around 4 to 5%. Even 10% I think is an overestimate. So what happens when there's hydrocephalus in a child with craniosynostosis? It's a double whammy. The brain is stressed both from within and from without. This is what happens. In a normal, everything is fine, the CSF flows, there is good CSF circulation, there is no problem, the brain is nice and relaxed like many of you are after the lunch. Whereas in craniosynostosis, the brain is tightly compressed from outside. Now you add hydrocephalus to it, the brain is compressed from inside by the dilated ventricles and from outside by the tight cranial wall. Now, what happens when there's a tight posterior fossa and there's venous thrombosis? Before the sutural fusion, it goes to hydrocephalus. After sutural fusion, it moves on to pseudotumor cerebral. Now this is an example of small crowded posterior fossa you have with hydrocephalus. Now does small crowded posterior fossa always lead to hydrocephalus? The answer is no. Nobody knows the cause-effect relationship, but definitely the association is very significant and it is very common. Now look at this. In a child with optic there is no hydrocephalus. That's the volume of the posterior cranial fossa. That is quite small. So you would expect the ventricles to be grossly dilated. No, they are not. Very minimally dilated ventricles. In fact, I would even pass it off as high normal range. We could operate on the child without sticking a shunt in the child. Now take this child with screws on. Again, small posterior cranial fossa, but grossly dilated ventricles, and this child needed a shunt to control the ICP before we operated the orbitocrotal advancement. Look at this child in a child with the left plagiosis, normal size posterior cranial fossa, normal volume of the posterior cranial fossa, yet the child has got very significant hydrocephalus, which means this child needed a shunt pre-op. I could never have operated done a fronto-orbital advancement without a shunt in this child. Whether you do a shunt or whether you attempt an ETV is up to you. But some sort of CSF diversion is necessary. The problem in ETV is it may fail because there may be associated cerebral anomalies and the flow may not be good. So, but it is, as I always say, the best shunt is no shunt. So, the less number of shunts you put in your children, the better for your children. So, ETV should be the first option. So, there are no hard and fast rules. If it is mild, sometimes if it is very mild, like we saw in the child, oxycephalic child, just treat the orbitofrontal advancement, allow the brain to expand, the child will be fine. There is no need to do anything to the hydrocephalus. Posterior fossa expansion, again I'll show you a case which we have treated, probably going to give good results. But again, that is a horrendous procedure. It's a big procedure with its own quota of morbidity. ETV is also emerging as an option, as we mentioned. Raised ICP, one of our worst enemies, one of our worst problems, most significant thing which we have to see. The intracranial pressure is raised in as much as 2/3 of the children with craniosynostosis. You name the craniosynostosis, unisutural, bilateral, polysutural, syndromic, non-syndromic. I can show you examples where the intracranial pressure is very high. People say scapulocephaly is the most benign because the intracranial pressure is never high. That's not true. I've had several children with scapulocephaly with raised intracranial pressure and a silver beaten appearance or plain films. Cranial volume can be normal. In other words, see what we have to understand is brain volume plus CSF volume is more than normal. So that causes the raised intracranial pressure sometimes, not necessarily the craniosynostosis. Venous hypertension is very common in the syndromic varieties where you have abnormal veins, abnormal venous drainage, malformed posterior cranial fossa, and those can cause hydrocephalus. Venous return, this is something which people don't talk about, but something that is very important. Small upper airway, the difficult act of breathing in these children causes impedes the blood return from the brain, and that causes hydrocephalus. This is from the classical paper by Marshak and Renier, and see the single suture incidence ICP more than 13 torr in 13% of patients. Whereas you take multi-sutural, it jumps to 42%. Now what you have to, the take home message is the raised intracranial pressure can be focal It can be global. Focal in the sense, let us say the child has a left anterior plagiocephaly. The left frontal lobe may be under very high pressure. You will find silver beaten appearance only in the left frontal bone. That's what you see here. Unilateral, one side alone has silver beaten appearance, whereas in bilateral, both frontal bones have raised intracranial pressure features. Of course, once you go into the global, the polysutural or the syndromic varieties, you have global effective raised intracranial pressure. Now, way back in '82, these gentlemen from Australia wrote this in their book. Some compensated mechanism takes place. Something happens. We really do not know what. Whether normal pressure has been recorded with significant convolutional markings and raised pressure has been recorded with no convolutional markings. So, what does that mean? This is a teenager with a Crouzon syndrome and she was doing very well in school. She had finished school and she's now in college after the surgery. But anyway, he was doing well in school with this kind of a skull. Take the child with scaphocephaly, look at the skull. See what is happening to it. That's Craniosynostosis with raised intracranial pressure. How do you explain that? It's very difficult to explain. So don't underestimate the incidence of raised intracranial pressure in children with craniosynostosis. Papilledema, we still encounter it. We should not be seeing papilledema in children with craniosynostosis because some of them do come late. We do have papilledema and it may be just needs close follow-up. Okay, ocular problems. What do we have? Now, if you see the anatomy of the orbit, it has bone on all sides except the front. So whenever something goes wrong in the brain, the eye gets pushed forward, the pressure inside the eye goes up. Now, the other thing which is important as far as treatment problems, treatment and management protocol is concerned is the growth of the cerebral bord parallel to the growth of the orbit. Now, the problem in craniosynostosis is the problem is in the skull base. Now, take the skull base like this. You have the vault sitting on top, you have the face sitting in the bottom. If there's a problem in the skull base, the vault above gets deformed and the face below gets deformed. So it is a hollow cranial, hollow head problem. Now, the volume of the orbit is 30 ml and the globe is only 6 cc. That means look at the amount of pressure the globe is subjected to when the thing comes out. Now it's a problem and this is not the place to discuss Morse's theory and Richard's theory on this, but it's just exactly what I explained. The problem is in the skull base. And abnormal reclusion of the orbital margin also leads to proptosis, but it's not too much of the issue here. Some basic considerations: that's normal, that's pericanthus, only the inner canthi are displaced. Okay? Whereas in true hypertelorism, inner and outer canthi and the cornea are displaced. Now, this is a child with true hypertelorism. You see the thing pushed away. Now, this is a child with pseudoproctosis. If you observe carefully, the apex of the cornea is at the same level on both sides, whereas the eye appears proctosed. That's because the bone has gone back. Some of the other problems in bilateral plagiocephaly, in any form of plagiocephaly, particularly in the bilateral form, the temporal lobe lies lateral to the orbit. because its orbit is pulled back and the temporal lobe is pushed forwards. Now the clinical importance is this may itself may cause some amount of proptosis. The other most important thing is when you are doing an osteotomy there, you have to be very careful, otherwise you may do a temporal lobectomy with your osteotome or your saw. Proptosis and acute deviation are almost always seen, particularly in the syndromic varieties. Now every form I have shown here, all of them have some problem with the globe. What are the clinical issues? Orbital stenosis, because the skull base is stenosed. Eyes can't be shut even when the child is asleep or even after induction of anesthesia. The lids stays retracted because the globe is come forward. And of course, we know about exposure keratopathy. Now, this is a child with Fisher syndrome, and watch what happens to the globe when the child cries. Also, watch how the child breathes. That's very important. See what happens to the eye? And you hear the snorting sound like that when the child cries. I'll tell you about that. Now, why the snorting sound comes is because of the small upper airway. The child tries to suck air in. The small airway does not permit so much of air to be moved into the lungs, so that results in this kind of a breathing. Okay, this is a bit of a controversy. I said I always do tarsography, and this is why. This teenager with a clothes on came to us. We did an orbitofrontal advancement. Post-op, we did tarsography. 5th to 7th day, the swelling completely subsided. The tarsography was removed, and 1 or 2 days later, the child presented like this. I was scared. I didn't know what had gone wrong. And to be honest, I didn't know what to do. I called everyone in India, everyone who does craniosynostosis surgery in India to find out what went wrong. No, each one gave his own explanation. I didn't know. So ultimately, I did tarsography again, and the swelling disappeared. Okay, the swelling disappeared, child is comfortable, everything is fine. I removed the tarsography sutures, this recurred. Again, I did a tarsography. But this time, after removal of tarsography, I said I'm not going to remove the sutures in a hurry. Then the thing happened, and after removal of tarsography, the child is doing fine. Okay, so we managed to save the vision. We even put topical steroids, topical methylprednisolone, intravenous methylprednisolone, intravenous decadron, you name it, mannitol, plastics. Nothing happened. This tarsography happened. There are people who advocate tarsography routinely, there are people who don't advocate tarsography routinely. I do it, that's my policy. If you want to do it, do it. If you don't want to do it, it's up to you. Okay, now this is another complicated issue in complex craniosynostosis. What happens to the hindbrain? What happens to the posterior fossa? What about the Chiari malformation? Now this is the incidence of Chiari malformation. Many of them are clinically insignificant. They can be best left alone. But you do have children whose Chiari has to be addressed. Now, one of the important things which causes Chiari is premature fusion of the lambdoid suture. that reduces the posterior cranial fossa volume. It's like a toothpaste, we are squeezing it and it has to escape in all directions. And one of the directions is it comes down into the cerebellar conference hernia. And again, this small posterior cranial fossa causes impedes the venous return. That in case compounds the issue. And we discussed the patho-ethio-significance of Chiari and hydrocephalus earlier. This is a child we treated earlier. Crouzon syndrome, untreated, came as a teenager. This is the girl who's doing very well in school. Chiari incidence. Now, obviously, the Chiari is very significant because the child has got a syringomyelia. So, what I thought was, I would do the orbitofrontal advancement, everything will get better. Sorry, it did not get better. And we find that it is still persistent. So we went ahead with the posterior cranial fossa decompression and the child is better now. I still do not have any imaging on this child because we have done a mid-phase advancement on this child and the child is doing very well. So how do we handle posterior cranial fossa malformation and hindbrain anomalies? No hydrocephalus or hydrocephalus is not active. Go ahead with the definitive surgery. The posterior fossa is tight. If there is no CSF space in the posterior fossa, particularly behind the cerebellum, behind the tonsils, go ahead and do a posterior cranial fossa decompression. If there is hydrocephalus, go ahead with an ETV or a shunt. Airway anomalies, we saw one child who had a bad airway, who had very difficult time breathing. Now, usually the lower face is always abnormal in these, the mid face and the lower face are abnormal. This is a reflection on the growth with the skull base as the template. All the structures are involved. There's hard palate abnormalities, short hard palate, cranial atresia, pharynx is not small, adenotonsillar enlargement. We'll again talk about that in a few moments. Chronic infection and enlarged, relatively enlarged tongue, recurrent URIs, recurrent lower respiratory infections. The child has a child with a syndromic craniosynostosis comes with a mild respiratory infection. We just put the child on antibiotics and we start. We don't wait for the respiratory infection to go away because it will never go away until the mid-phase is advanced. Some become obligatory mouth breathers. Now you see this. Every child with the small mid-phase is small, the mouth is open, the tongue is protruded, accessory muscles are working, they may even have intercostal retraction, the alar nasi are flared, and look at the small upper airway. Pfeiffer syndrome, one of the worst. As I told you earlier, you may have to do a pre-op tracheostomy. We had to do a pre-op trachea in this child before we could even go anywhere near the head. Because the child has so many issues related to respiration. We have now successfully weaned the child off the tracheostomy, but the child has not made a significantly improved neurologic outcome. That's because of the disease process. OSAS. Now this is a very, very important issue, something about which we don't talk often. So, it's a dreaded anomaly. It is a respiratory problem and enlarged. The adenoids and the tonsils are usually chronically enlarged in these children from repeated upper respiratory tract infections and lower respiratory tract infections. That makes OSAS worse. You have to be acutely aware of this condition. The mother says the child is not breathing very well, the child is snoring a lot, and at night there is a problem. Child wakes up gasping and things like that. Don't ignore it. That's a sign of OSAS. Several things have been done, adenoidectomy, pre-op before craniofacial advancement. You just put a nasal trumpet, nasal airway, coronal dilatation, tracheostomy, you name it. And but the best is mid-phase advancement. I have lost a child with Croton syndrome after uneventful orbitofrontal advancement. Child was alright for several years after that, but then the child developed OSAS and the child succumbed to it. It's in no way related to what I did, but this is related. The mortality is due to OSAS. Non-syndromic, don't think that only the CNS syndromes cause, as Professor Mahapatra said, 100 plus syndromes have been associated with craniosynostosis. Some even include metabolic disease, inborn errors of metabolism. Some examples which we have treated. I still don't know what this is. Dysostosclerosis. I even have difficulty pronouncing it. Dysostosclerosis. It's a kind of mucolipidosis who underwent surgery, mucopolysaccharidosis who underwent surgery. So what is the take-home message? Don't underestimate craniosynostosis as an issue. Don't say, it's one leave anterior plagium and we just do an advancement. No, that's when you get into trouble. Always be acutely aware of what can go wrong with the child, the complications associated with it, particularly with respect to the airways, intracranial pressure, and breathing. And you need a team. You can't. This is not a one-man show or a one-person show. You have to discuss each and every case with your anesthetist before surgery. All my children go to the ICU after surgery for at least 24 hours. And if I anticipate any issue with respiration or breathing, I alert them, I tell them I want a ventilator standby. It's an overkill, possible, but that's what we have to do. I think I will stop here. Thank you.
So you done with the second talk?
Sorry?
So you done with that second talk as well?
Okay. The second talk is complications, right?
Yes, sir.
Okay, we have waxed eloquent about craniosynostosis in the last few minutes, and we have seen some surgeries, and let us see what does, and what will go wrong. There is no such thing as a preoperative complication. I put it there because I could not find a better word. But these are problems which are related to the disease, which lead to increased mortality and particularly morbidity. Then we look at something that can go wrong during surgery, something that can go wrong after surgery. I'll show you some examples from the complications, some of the complications I have faced, and I'll also tell you about my series and the reminder. Okay, preoperative problem. We have looked at this slide before. Raised intracranial pressure, single suture with multiple suture stenosis, both in both the conditions, intracranial pressure can and is high. So be prepared for raised ICP when you are operating. The child we saw today is an example, the child with brachycephaly. And this we have discussed earlier, focal versus global. This the child with oxycephaly, look at the wall, and this is what we found at surgery extensive. See, the problem in this situation is the superior sagittal sinus often lies in a groove or even in a channel. So when you are dissecting, there is a very high chance of making a hole in the superior sagittal sinus or even tearing it. So be very careful. Focal and global we have talked about. Ocular problems, exposure keratopathy, and this child lost that eye due to perforation of the cornea in spite of advanced treatment. And we saw the eyes popping out in a child. We saw the video in the last talk. There's another child with Pfeiffer syndrome, advanced Pfeiffer syndrome, and see what happens to the globe and the child tries. This is, the child was so bad, the anesthetist said nothing can be done, it will be so bad. Airway is so bad, breathing is so bad. So desperately, I did the posterior decompression, just remove the posterior parietal occipital bone to throw it away. I said, let's see what happens. Child improved. Child put on weight, the respiration improved. But in spite of it, it's reossified, and look at what is happening when the child cries. Now, an interesting anecdote, children with Crouzon syndrome are very intelligent. Some of them, they go to school and they take off their glasses and who trained like that, the eye will pop out. The teacher gets scared. You go home, you go home. So the child goes home, puts the eyeball back and starts playing. This is well known and I have seen an example of that. Small airway, we have talked about it earlier. They're all obligatory mouth breathers, alar nasopharyngeal and a tongue protruding. This we have discussed earlier, so let's not repeat it. Okay, what are the intraoperative problems? One of the most dreaded complications, see these are long surgeries, these are bloody procedures, the child's bone is very vascular, the child can bleed a lot from the bone. So be very careful because when there is skin, you make a long skin incision, particularly if you're going to make a wavy incision, it's going to double the length of a straight incision. Desperately, in some cases, I have tried injecting local anesthetic with adrenaline, it did not help. Sometimes, in one or two cases, what I've done is marked out the incision, put a skin suture on either side of it, and then I made the cut, no difference. It still bleeds. The other problem is dural venous sinuses. They can bleed a lot. I have lost one child from bleeding on the table. That's not the child who had the air embolism, it's another child. So be careful, be very wary of it. Something which people don't talk about is dilution. You just keep pumping packed RBCs or whole blood. You don't give FFP. The whole blood gets diluted. There are no clotting factors. There will be enough RBC. The hemoglobin will be good, but there will be no clotting factor. There will be no platelets. So, as a rough rule, what we do in our OT is for every unit or every second unit of blood, we always transfuse FFP. If there's a doubt, we give FFP before even giving blood. Same thing with platelets. If you're going to give something like an exchange, or even less than an exchange, 50% of an exchange, the child must get a platelet transfusion. Either in the OT or post-op, the children must have platelet transfusion. The other thing is they always lose blood into the dead space after surgery. So you may have to check the hemoglobin and the hematocrit at least 12th hourly or if not 8th hourly, and top it up if it keeps falling. Standard neurological techniques, meticulous technique, there is no excuse for not using it. Head elevation helps. Management of raised ICP, not letting it get out of hand. If there is massive blood loss, try to control it before proceeding. Don't take it lightly. Craniosynostosis acid, my anesthetist swears by it. I think the dose is approximately 30 milligrams per kilogram. I don't remember, but we give an infusion of craniosynostosis acid before every craniosynostosis case. In fact, before every neurosurgical procedure, even for vascular tumors, he swears by it. Air embolism, I told you it's about 67%. That is 2 out of 3 children will have it. Use standard techniques. I mean, when we were operating on posterior brain and posterior tumors in the sitting position, we took certain precautions. Take the same precautions. Thorough irrigation. What happens if you have an air embolism, significant or non-significant? Irrigate flood the wound with saline, flood the wound with irrigating fluid, put dripping wet gauze packs or pads on the wound, pack and wait. I really don't know if it helps, but for legal reasons, you have to mention it. Because somebody will say, did you put a central line and aspirate the air? You must be able to say yes. Raised ICP is a serious problem, use standard techniques. See, very often when we operate on these children to check the correction, we flex the neck, we extend the neck, we move the neck this way, that way, do the head this way, that way. All those things can ink the neck veins and cause problems and make the venous return worse. So keep the head elevated. Diuretics, 1 or 2 cases we have had to give diuretics before we could retract the dura and get the orbital bar out. Treat hydrocephalus. Dural tear, it is never too small or too minor to be ignored. If you have a doubt, ask the anesthetist to give valsalva maneuver and check for leaks. The problem very often we ignore is the tear in the periorbital. The orbital tract will prolapse and we may ignore it. Don't do it. That causes worsening of the orbital and conjunctival edema post-op. If there's a problem in closing the wound, which happens if your child is small or if you have a syndromic variety like Luzon or Apert or polysutural synostosis when you have done an advancement. That's one instance where a baby incision helps. You can really mobilize it. But if you still have problems, do a wide undermining of the area. And then you can easily close it without tension. I've had only one problem, one patient, child with flower leaf who had a wound problem who needed post-op plastic care. Okay, now what happens after surgery? Infection. Fortunately, I've had only one major infection in my series. That child needed prolonged course of antibiotics, daily irrigation of the wound with iodine solution and garamycin before we could do anything. Fortunately, the child did not get any osteomyelitis or osteitis. Meningitis and infections spreading from opened airway, sometimes in an old child, you may open the frontal sinus. That can push the thing inside. The most dreaded infection, in my opinion, is pneumococcus. That can kill the child within 24 hours. And pneumococcus is a very good, it's a common bug in all your airways. So be wary about pneumococcal infection, sepsis-related problem, transfusion-related problems. As I told you earlier, if you don't give adequate plasma and adequate platelets, you are going to have dilutional problems and that can cause post-op blood loss. There is always a drop in the hemoglobin PCV, and we don't transfuse blood in the post-op period if the hemoglobin PCV are 8 and 24 and above. We just give them some iron supplements or some multivitamins and the child picks up. And I don't like drains because I think it causes more bleeding and more blood loss. So we stop using drains. Seizures are very, very rare, but they're not unknown. And ocular conjunctival edema, I showed you a case in a few moments ago. Infection, I'm not talking about meningitis, I'm talking about wound infection and others. There are a lot of free bone, the entire vault is free bone. You have put a lot of implants, some absorbable, some non-absorbable, and they are waiting to get infected. Staph is often the troublemaker. As I told you, they may need prolonged course of antibiotics. Bone resorption occurs, and I'll show you an example. The free bone flap, it's not a vascularized bone, so it can get resorbed. Sepsis makes it worse. Lesion graft may be needed. Implant pull-out, every once in a while you have the wires pull-out. When we were using wires, we stopped using it. That's the reason why we use observable implants. Some examples from my collection of cases. This I told you about. This child had a massive extradural hematoma from disseminated intravascular coagulation. I don't know why the child developed it. Possibly we did not give enough platelets, we did not give enough plasma. Maybe it was a transfusion related problem. We still haven't got an answer. But eventually we reoperated on the child, but we lost the child. Corneal perforation in spite of therapy in a child with bad fever syndrome. Growing fracture, I told you a few moments ago, no dural tear is too small to be ignored. The dural tear is ignored. They often go in for growing fracture like this. This is time with tapers, we have to reoperate and fix that with a duroplasty and bone graft. Bone resorption does occur even if there is no infection. This child resorption was slowly expanding and it was significant, so we had to put a rib graft to cover it. An abnormal bulge or an abnormal deformity does occur, and this child also needed a cranioplasty. Fortunately, the bone, we had adequate bone at this site, so we could remodel the bone and fix it. Now this is, we have reliable data, I mean dependable data for 180 cases of craniosynostosis we've operated recently. The number, some of them have now come back at a later stage for some complication. I told you there were two intraoperative deaths, one each due to massive bleeding and one due to tear embolism. One in the immediate post-operative period of DIC, I just showed you the pictures. Wire perforation, so we don't use wires, a handful of cases of that wire perforation. Seizures we could easily control with medication, and we withdrawn the anti-epileptics. Superficial scalp infection, it's needed just oral antibiotics for a week or 10 days. Wound adhesions, resuturing in one, and a plastic surgery procedure where a graft had to be put in one child with Prader-Willi syndrome. One needed prolonged antibiotics. Reoperation, growing fracture, I showed you the picture. Unacceptable result. One was a child with craniosynostosis, one was a child with scaphocephalic. I had to reoperate. Bone resorption, I showed you one case, and there is one more waiting, but they have not come, and I am not too sure how good or how much the bone resorption is. Quad deformity, I showed you the pictures. Pseudomeningocele, who needed a lumboplatonic shunt to manage it. Into, we just waited, it went away. Some of the pseudomeningocele, like you have after posterior cranial surgery, it does go away after a few weeks. Conjunctival edema, I showed you. Corneal perforation, I showed you. So there are not many. I mean, you don't have too many complications in this procedure, but it can be serious. It can be life-threatening. And the major intra-op problems are bleeding and air embolism, infection, ocular problems, and bone erosion are common cause of problem. Thank you very much. Has anyone had any other complication which I have missed? I don't know. I'm just asking. I'm throwing open that question to the floor. Deepak, have you had any complication apart from what I have mentioned? Anybody else, Shekhar? I don't know. Maybe my incidence is higher, but this is what I have had. What about you, Arthur?
I had an unusual complication. I lost one baby, and when I was doing the surgery, the PCO2 of the child was rising continuously. Like I was doing it at 50, and then suddenly I was told the PCO2 rose up to 70s and then 80s, and suddenly boom, boom, cardiac arrest. And what I was told by the anesthetist subsequently was maybe because of tissue retractor which I had used, they caused some amount of flexion of the neck. They did not put any flexometallic tube in the child, because then I later on found out that even for children, very young children, you have number 3 flexometallic tubes are available now. So some of these poor kids, when they have some amount of flexion because of the tissue retractor, the tube can get kinked, and that can be disastrous. Your surgery can be absolutely fantastic, but you know.
Yeah, operation successful, patient dead. No, yeah.
I have a comment. We are really very radical if we about bleeding. Yeah. I start the operation only if we have blood concentration in OP room. Is a point. Another point, aspiration is forbidden. Yeah, complete forbidden. Because we must give the nature the possibility to do the natural hemostasis. If you the all time the resident have this bad custom, aspirate, 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 and you aspirate it close. It's not necessary. Put a towel, a wet towel over, and wait 2-3 minutes. Then it's okay. Yeah, this is I think because we don't have a big problem with the craniosynostosis surgery. Our problem, what we very often have, is the sense of the closure. That we have, yeah. But another complication.
One comment about what Deepak said and what Arthur said. We have tried plain tubes, we have tried gray tubes, but now we find flexometallic tubes are the best. So, if you're anesthetist, if you don't have a flexometallic tube, I would suggest these are not emergencies. So you can wait for a day or even for a week before you get your flexometallic tubes. The other thing is about bleeding. Be very careful and don't be over enthusiastic. The moment I take the knife in my hand, my anesthetist says, get the blood.
Yeah.
Sometimes even when he puts the arterial line and has difficulty, I tell them surgical blood loss is 100 ml, arterial line blood loss is 200 ml. Because they have difficulty putting arterial line. So unless, not only should blood be available, plasma and platelets must be available. Otherwise, they will start these.
Yeah, this is very important because the cardiovascular state can discompensate very quickly. Very quickly. The patient get good, then 30 seconds later, hypotension and bradycardia. It's difficult. A nice presentation.
I think Ramesh can present.
Light off कर दो.
I'm going to talk about the modified technique of the plagiocephaly. These are all the classic symptoms of the features of the unilateral synostosis. The ipsilateral orbits are higher and wider than the other orbits. Nose may be deviated away from the side of the forehead flattening. Eyeball appears protruded because of the flattening on that side. There is severe constriction on that side. Supraorbital contour flattening on the affected side. CT showing the coronal synostosis. Classic Harlequin sign where there is upward elevation of the sphenoid vein, which is seen on the CT. Also, the greater wing of sphenoid is expanded, displaced forward and downwards from relatively large middle cranial fossa. The middle cranial fossa which is large. Nasal septum and crista glabella and ethmoidal complex are tilted on the side of the fusion. These are the areas where there is a fusion. The aim is to break the synostotic forces of the skull base, roof of the orbit and the coronal suture and provide the functional and aesthetic result. In the past, we used to do bifrontal craniotomy and advance the orbital bandu unilaterally, keeping the pivotal point on the normal side. And additional bone graft is placed as a camouflage to prevent the correct the supraorbital flattening. This is the flattening in that area. The bilateral advancement with the camouflage and the supraorbital rim fixed laterally with the biodegradable plates and screws, and this is how you can achieve. 85% of my patients had a squint because of the tilting of the neck. There is vertical squint, which is treated by my ophthalmology colleague by splint and squint treatment and surgical correction. You can see that the supraorbital rim is maintained all throughout in the longer part. The long-standing result here, you have a pointer? Long-standing result because there is a symmetry which is maintained. Another patient treated with bilateral frontoorbital advancement. Another patient with bilateral frontoorbital advancement. What happens in bifrontal is there is you take extra time, extra blood loss, and also more bony defects. So we have decided to go ahead with the planning with the unilateral frontoorbital advancement, where there is flattening on this side with craniosynostosis. What we do is that we take a malleable retractor and take the curvature which is required to reconstruct the opposite side of the frontoorbital region. And we select the area which is as compared to the opposite side. You can see that this is a requirement on the non-affected side. And we place that area and create the area of the craniotomy where you have to create the new frontal bone with the advancement. When we do that frontal craniotomy with the required new frontal element, in the orbital area there is a sphenoid ridge which is required to resect it while taking the cuts onto the roof of the orbit. So that is the area where that Harlequin sign which shows that there is a synostosis in that area. Some of the areas may require the orbital bending by using the bone bender. And this is how is the new orbital forehead with the orbital complex which is fixed with the help of PDS sutures in new position. And this is the entire assembly is placed to its new position, fixed to the opposite side and fixed into the temporoparietal area. You can see the round table, you can provide a good result. This is the pre-op and the post-op. The warm side. Another girl with the plagio, similar technique. You can see that the fixation with the PDS sutures in the new forehead is fixed to the opposite side and to the temporal area. You can see that it is very long standing results showing that it is maintaining well. You don't require any plates and screws, you can maintain well with the PDS sutures. Another patient with a similar technique, anterior contouring as well as advancement. Some of the patients they do require the posterior release too. You can see there is a long standing showing a good supraorbital limb which is maintained. She also undergone squint surgery. This is a warm side showing the maintaining. There is 13-year follow-up. Another patient, similar technique. See that 5 years follow-up. Very severe form of tilting of the neck. This is the galeopalatal flap we raise where there will be a skeletal defect left here. In this case, this is the advancement which is required. We've taken this particular segment as a new forehead, that is A. And we did a frontal craniotomy on the unilateral side. Did the posterior release. There are three segments. The A segment is used for the forehead. The orbit is mounted on that forehead. And this one it is fixed laterally in the fixed area, fixed in medially. And the B segment is placed back. This is the galerie flap which goes on to the defect. Rest all areas are filled it with the help of a bone dust. This is the result on table. And this is the symmetry which is achieved, and even the neck got corrected. Another patient with a similar type of technique. The posterior release. If you require more advancement, then you may require the additional bone graft in the temporoparietal area. And this is the result. Advantage of this particular modification, it provides good bone-to-bone contact and better graft survival. PDA sutures are relatively cheaper than the biodegradable plates and screws. It does not disturb the normal side of the skull, hence less blood loss, less duration of surgery and bony defects. So the proper assessment is required. Post-operatively, squint management. Some of the patients they do develop orthodontic treatment is required. I'll show you a video about 11 minutes duration. Bicoronal flaps. I do a lot of hydrodissection to begin with. I use hyalase in my infiltration. Lignocane with adrenaline, hyalase, sensorcan, and double dilution of adrenaline 500 cc of ringal lactate. Infiltrate along the line of incision, I infiltrate in a subdermal plane, and along the direction of the flap, I infiltrate into the subgaleal plane. And this is the flap which is raised, galioperitoneal flap. Then in the area of the orbit, continuous irrigation is required, otherwise this galioperitoneal flap gets dried up. In the area of the orbit, the frontozygomatic junction, the supraorbital ridge. With the dissection is done on the roof of the orbit, also in the midline. We don't go to the opposite side of the orbit, it is not required. Do the dissection only in the midline and the affected part of the orbit. This is how the measurement is taken from the normal side. Then you decide which is the area which is required, which is going to give you the good frontal correction as compared to the opposite side. And then the anteroposterior, another malleable retractor to take the curvature of the anteroposterior curvature. Then you decide which is the area which is required. Then you mark that area as a separate frontocraniotomy segment, which will be your future orbital rim and the forehead. So this is medial, that is lateral. Then this is a part of the orbit. This lateral element sits on this temporal area, which is the fixed area. In multiple boreholes, we collect all the bone dust.
should be very careful in this area because that is the area of the sphenoid ridge. This is the dissection of the roof of the orbit. That is the area where there is a sphenoid ridge. This is your new forehead. The sphenoid ridge is cut in that area, very close to the roof of the orbit. Then the half of the orbiter, the lateral wall of the orbit, take it right here. Take the cut with the guide, the lateral wall of the orbit. And with the help of a cutting burr, either a Lindman burr or with the help of burr, Fisher burr, take a cut on the roof of the orbit to protect the dura from above, protect the orbit from below. Let's see that tip of the burr which is coming into the orbit. This is how you take a cut on the medial wall, lateral wall, and a sphenoid. With the help of the osteoton, this is the toughest structure. The sphenoid part is the toughest structure. You have to go flush with the roof of the orbit and the lateral wall. This is how the unilateral orbital banding which is removed. When you decide which is the points where the orbit is going to fix to your new forehead, these are the posterior decompression where you take the release incisions and then you, with the help of bone bender, you restrict all the multiple cuts, which gives additional expansion into your posterior part. This is a fixation onto the new forehead. This is number 1 PDS. All the knots are taken inside, so they don't feel from outside. See that? Exactly fitting to this area. Just fix it temporarily with the help of a long artificial set. You retrace your microphone flat to see whether the fixation is proper or not. Once you're sure that the fixation is good, then you mark the points which are required to the fixation. Multiple fixation. And the lateral part, you require both the walls. The lateral temporal part of the bone, which is overlapped by the body perimeter. The TCL bone bender is another good instrument you should have in your armament. See that going through the bone, coming out and coming out from the same bone, and then it is tied on to the leg. It achieves multiple level bone to bone contact.
that bone bender is being of the school one. The placement of the all bones are very important. All the edges are burned. Part of the super organ. It keeps in position because of the overlap of the bone in this area. The relay flag goes into the area of the defect. This bone was placed into that area. Sometimes I do take lateral canthal stitch here, going through the bone. It hitches your canthus into position. Hitch of the relay flag. Thank you. Questions? Maybe. To give a contour of that and look for it. Look for it already achieved the put on the opposite side curvature. We take that curvature the front for it. It is come from inside. We are already bended with the help of a bone bender. It achieves the contour of the new forehead. Intraorbital is formed by the new forehead. Inside that, you are including that existing orbital band. We are not shifting the position of the orbital band. We shifted along with the forehead gap. Should have long-term results. Very, very important. Long-term results which are shown that shows the success of the about 30-year follow.
I think it is very unfair for the audience to listen to boring lectures at 6 o'clock. The, the diagnostically, I think, has been demonstrated today in the morning, and this is one operation which can give very satisfying results in majority of the patients as far as cosmetic appearance is concerned. And we know that this happens because the topic suture gets fused prematurely, and as a result, the forehead tends to become granular in shape, and that's why the name Craniosynostosis. So the features are that there is granular shape of the forehead, and since the myopic area gets fused prematurely, the intercanthal distance also becomes less. So invariably, all trigonometries will be associated with some kind of hypotenuse. And in some situations, there can be associated supraorbital recession also. So, like look at this child, at the age of 3 months, you find that the forehead is quite triangular in shape, and you will also notice that it is so severe that there is some element of supraorbital recession on both these sides in this child. And this would happen in very severe cases. And at the age of 10 months, we find that the deformity has become worsened. The supraorbital recession has increased even further. We find that there is an element of hypotenusism. This is small because this area is not growing proportionately in the rest of the body. So the forehead is narrow, it is pointed, and there is decreased intercanthal distance. So the requirements for traction would be that we have to increase the width of the forehead. The forehead which is pointed needs to be flattened, and if the hypotenusism is marked, this also needs to be addressed. And I feel that in majority of the situations there is supraorbital recession which also needs to be addressed. At least we have to control it. So the steps would necessitate that we go through all these stages of tracking this patient. So the coronal incision, as I have discussed in the morning also, needs to start from the post-orbital region, and this is in a zigzag manner. The zigzag manner helps in camouflaging this scar because a broken scar line is less visible. And so it is important that the scar should not be sterilized. And this is once again to highlight that the incision should start way back posteriorly. Another key point in doing coronal incision is that the edge of the incision should be beveled. This helps us in having this area of the scar without allocation. Otherwise, what is going to happen is in the area of the scar, there will be allocation, scar allocation. But when you bevel the edge and when you are suturing them, then the hair follicles from the one end of the flap will go through this scar. So this is known as glycophytic closure. So this small trick helps a lot in having a scar which is virtually non-allocation. Dr. Nitin has already alluded to this fact that it is of paramount importance that we should decrease the blood loss. The bony, when we are doing bone work, the blood loss cannot be minimized there. However, while raising the toning hair, the blood loss can be minimized to 10 or 20 cc. This can be achieved by liberally injecting by dilute saline solution. Saline in concentration 1:500,000 can be used liberally. This achieves two effects, that it does hydrodissection and it also leads to chemosensitivity. So the bleeding is minimal. And so, as you can see, that when we have given more saline injection, and when you incise, hardly there is any blood loss, and majority of the dissection can be done in the field which is virtually clear. liberal use of bottling in subgenital care also. And so when we have dissected the flap in the subgenital vein, with the help of the bottling, again I would like to highlight that you will find that there is hardly any bleeding here. Right? It is totally a breast feed. So as we reach towards the superiority margin, we will stop here. Another trick which helps in safe elevation of this flap without damaging the frontal branch is that we use a blunt periosteal elevator like a parabolic periosteal elevator in the temporal region so that the frontal branch gets lifted off into the flap, so it will not be damaged. And this trick helps in avoiding the inadvertent injury to the frontal branch, which can be very irritating. So after we have given the coronal cut incision, then about 2 centimeters above the scrotal margin, we make the cut subperiosteal, and then on this section at this level 2 centimeters, we will start setting it the subperiosteal. This is supposed to be position, and there are some unique points which can be tackled by the use of the So when we are in the region of the root of the nose, I found that it is quite useful to give a releasing signal in the pericranial hair so that it helps us in the second in the region of the root of the nose. And the flap gets elevated very easily. And we will expose the lateral auditory margin till about the frontal auditory supervision, and immediately we will expose the root of the nose. Then next, rest of the pericranial periosteum from the imperial wall is completed. This is a small child in which we are doing this review. So some people are not with it. So we have to be careful that we don't inadvertently damage that. And then after the bones have been exposed, then we have to mark the flap. As I have already suggested that in several of these patients, there is superficial recession. So it makes sense to make a bifocal flap, so which is being marked here. So after this flap has been marked, then we have to do neoteny, which is now being formed. Needless to say, all this bone dust is preserved because this can be very deep and we keep more irregularities. Neoteny this region can be tricky because the bone is very thick here. And then after separating the liver, neoteny is done. In this patient, we were using really soft, but is your personal choice you could use all instruments. So after the bone flap has been removed, then we had to do dissection in the region of the root of the orbit and the region of the bones. And so that now we are ready for the next stage of more frontal segment. So frontal segment, the second is that we separate the embryos from the root of the orbit in the region of the root of the nose, and then with the help of reciprocating saw, I'm quite comfortable with reciprocating saw. First, I'm made in the roof of the orbit,
which go medially up in the root of the nose, and actually it will be little orbital muscle. And once these have been made, and you are sure that the cuts are complete. Now, you will also notice that we are using a spoon for reflection of the orbital globe. I find this is very handy because the globe sits very comfortably in that position. The cut is given at the age of conjunction, and then once this is done, the little cut is extended, being extended, and the orbital bone is being cut on the other side also. And once this is done, the frontal segment can be removed after making sure that all the bony junctions are taken care of. So you might have to use the osteotome at one or all place. Then I have found this use of this Smith-Peterson separator to separate this frontal segment very handy. This segment is then taken out, and we ensure that there should not be any dual tear at this time. There are many ways of manipulating this frontal segment. The main purpose is that we want to reshape it. So in a smaller child, the bones are pliable, and with the use of strong bone forceps, you could press them and mold them. In an older child, you might have to resort to weakening this bone by the use of oscillating saw or use of burr, so that it becomes weakened, and then you can use bone forceps to mold it. This is one step where we are showing that this bone, thick bone in the center, is weakened, and then once it is weakened, then this can be hammered to become flattened. I find that this method very useful. This looks crude, but it is very effective. And even if it gets fractured in between, doesn't matter. You can put a plate or wires. And this is what I meant, that you can use heavy forceps to give shape. So the bone, which was conical, has become flattened. And as I said, that in these patients there could be an element of hypotelism also. So I will come to that. If there is some element of hypotelism, then what we can do is that in the region of the root of the nose, we could make a vertical cut, put a Smith-Peterson instrument there, spread it by about half a centimeter, and in that region you put a small wedge of bone so that it gets moved depthly. So this is the same child, 1 month postoperatively, and this is 2 months postoperatively, and we find that the forehead is flat, and this is in 2 years postoperatively, and this is in 3 years postoperatively. Another child who was operated when she was about 2 years of age, and this is when she was about 7 years of age. Late result of this child, this is I think about 5 years postoperatively. So trigonocephaly is one surgery which, in my experience, I feel is done primarily for cosmetic reasons only. These patients don't have any other functional issues, except that probably they have some problems with their emotions and adaptive functions. Other than that, there is no functional issue, and reasonably good results can be achieved in majority of these patients. Dr. Nitin Mukal has already said a lot about plagiocephaly, and in the morning we also did one case of plagiocephaly. So the plagiocephaly is because one side coronal suture has got fused, so the frontal bone on that side is not increasing, it's not growing, and so it gets recessed and pressed. And not only that, there is upward pulling of the sphenoid along the sphenoid ridge, so the orbit tends to have an orientation which is more vertical rather than oval.
And again, so there is dissection of the forehead. So in this patient, as you can see, there is constricted growth of the frontal bone here. This orbit seems to have been pulled up. This aperture is smaller as compared to this aperture. Dr. Chidambaram has already said that in some of these patients, one has to be careful that there could be an element of raised intracranial pressure, which can be, we can note it by noting some printing on the X-rays or even on the CT scans. And about 10% of these patients might have features of decreased breathing also. But in non-syndromic patients, majority of the cases, the plagiocephaly doesn't have any functional derangements. So the need for surgery in a non-syndromic patient would primarily be for cosmetic reasons. And as we would notice that in most of these patients, the root of the nose tends to get pulled toward the affected side because that side the nose is not growing. So there is a deviation of the nose. And if there could be torticollis and squint, as Dr. Nitin has so beautifully shown. So these could also be part of the plagiocephaly. Needless to say, infancy is the best time to operate because these skull bones are moldable at that time. So the principles of management would be that if there is, we have to increase the cranial volume on the affected side, and then we have to reshape the mold in such a way that it is symmetrical with the normal counterpart, and orbital advancement would have to be done. There is always a discussion on whether we should do a bifrontal craniotomy in a case of plagiocephaly, or it should be a unilateral frontal craniotomy. I feel that it is much more easy to do a bifrontal craniotomy, and then you have more leeway to experiment with the bone flap which you have got. You can adjust it. Otherwise, if you are doing only on one side, your options are limited. So I have always preferred to do a bifrontal craniotomy in a case of plagiocephaly. So this patient who has marked the section of the supraorbital ridge here, there is flattening of the forehead, and as you can see, there is fused coronal suture which can be even through the skin, and the coronal suture here is fused. This coronal suture is increasing, so this is restricted on this side. And so this is the frontoorbital segment which has been removed, and you will appreciate that this is the normal side, and the segment on this side is recessed by this much. So this needs to come up by this much distance. So if you are doing it early enough, then since the bones are moldable, you could mold it and then keep it in that position with the help of plates and screws, or with the help of bone plates also. So this patient then underwent correction. This is, I think, 1 year after her surgery. This is 10 years, at the age of 10 years. You will notice that the distance between the two temporal apertures is almost near symmetrical. The forehead flattening is corrected and it is maintained. And this is her when she became 20 years of age. And you will notice that just with one surgery, we had been able to achieve a result which has maintained over the next 17, 18 years. And so from there, at the age of about 1.5 to this, just after one operation, it gives a very encouraging message that if the patient is treated at an early age, it can give lasting results. And this is her when she came when she was about 20 years of age. You can see the forehead looks symmetrical. The skull is almost normocephalic, and the eye is almost near normal. And the smile says it all. Another patient with more severe craniocephaly. Here again, we notice that the eye also needs to be addressed apart from the forehead because the orientation of the eye is not, the growth is not correct. So this shows the same things which I did in the case today. We have this frontoorbital segment which has been removed. And I have tried to show that this is recessed by this much distance. You would also notice that the orbit on the affected side, an osteotomy has been done, and this has been moved laterally by about half a centimeter to increase the orbital cavity in the horizontal plane. And then I find it is very difficult to correct the recessed supraorbital margin in the frontoorbital segment. So I have now started using an only bone graft, which is appropriately shaped to match with the other side, and then hold it with just positional screw. And this helps in giving a shape which is quite pleasing to the eye. And since I have taken a bifrontal craniotomy segment, so I have a lot of freedom to experiment now. So I realized that in this patient, if I were to move this segment by 90 degree and this segment by 90 degree in the directions which are shown there, I would be able to achieve a forehead which is almost matching with the forehead on the other side. So this is a simpler way of doing it. Although I am also achieving the same thing Dr. Nitin had done by choosing it before doing the craniotomy. But the advantage with this method is that you can change your plan till the last minute. So this is the same patient 5 years later. You would notice that there is slight irregularity here, which is expected in some patients because not all patients behave the same way. But the distance of the palpebral pressure on both sides is maintained. The supraorbital from lower lid to the supraorbital surface, the distance is almost matching. And this is her at 7 years of age, 7 years later. Another patient with Craniocephaly, rather severe deformity. The orbit here is almost vertical. Here again, similar principles are used, and as you would notice that the orbital segment is given shape by an only bone graft. And this is her 5 years later. I would say the shape is reasonably well maintained. The